tumeshuhudia uongozi ulio bora. Hongera serikali yetu na maendeleo. Hongera serikali yetu na maendeleo. Tunafurahia matunda ya uhuru wetu. Kweli tumepiga hatua kwa maendeleo. Tunafurahia baba matunda ya uhuru wetu. Kweli tumepiga hatua kwa maendeleo. Barabara zimejengwa kote nchini Kenya. Usafiri sasa umekuwa bora sana. Barabara zimejengwa kote nchini Kenya. Usafiri sasa umekuwa bora sana. Hongera serikali yetu na maendeleo. Hongera serikali yetu na maendeleo. Tunawahimiza tupange familia zetu ili serikali iweze kujipanga vyema. Tunawahimiza sote tupange familia zetu ili serikali iweze kujipanga vyema. Tuzae watoto wale tunaweza lea, wapate elimu, matibabu, malezi bora. Tuzae watoto wale tunaweza lea, wapate elimu, matibabu, malezi bora. Hongera serikali kwa umoja wetu kwa umoja wetu. Hongera serikali yetu kwa umoja wetu kwa umoja wetu. Hongera serikali yetu kwa umoja wetu kwa umoja wetu. Hongera
Okay, wacha niweke mic. Unanisikia?
Nakusikia.
Tunaipongeza serikali yetu Kenya. Tuna maendeleo mengi kote Kenya. Tunaipongeza serikali yetu Kenya.
Bwana Zomo,
Tunayo imani na serikali yetu Kenya.
Zomo,
Tunayo imani kweli na serikali yetu Kenya.
Zomo, Bwana Zomo. Bwana Zomo,
Tunafurahia matunda ya uhuru wetu. Tunafurahia matunda ya uhuru wetu. Barabara zimetengwa kote nchini Kenya. Usafiri sasa umekuwa bora sana. Barabara zimetengwa kote nchini Kenya. Usafiri sasa umekuwa bora sana. Hongera serikali yetu na maendeleo. Hongera serikali yetu na maendeleo. Tunawahimiza tupange familia zetu ili serikali iweze kujipanga vyema. Tunawahimiza sote tupange familia zetu ili serikali iweze kujipanga vyema. Tuzae watoto wale tunaweza lea. Tuzae watoto wale tunaweza lea. Wapate elimu, matibabu, malezi bora. Hongera serikali pamoja.
Then I unmute, and then it comes the host has unmuted everyone. Let me unmute again. Let me leave this one. I leave this site right now. I leave the.
Our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our vision at NCPD is to improve the lives of Kenyans. NCPD and support population programs. Our mission at NCPD is to manage the population. Oh, our mission at NCPD is to manage the population. Oh, our vision at NCPD is to improve the lives of Kenyans.
You just speak it, sorry, it's in the background.
Good morning, good afternoon, wherever you are watching us from live. My name is Peter Nyakwara. I work for the National Council for Population Development. I'm going to moderate today's session. And I wish to start by a warm welcome to you all for our second day of the fourth National Leaders Conference on Population and Development. Yesterday we had a very interactive session, and I believe today's session are going to be very, very interactive. We are going to have 8 thematic areas we are going to discuss today, divided into 5 breakaway sessions, and we can project so that we can go through those sessions so that we give how we will be moving. The first session will run up to, the first set of sessions will run up to 10. And the first session, which is reflected in yellow on your screen, will remain in the plenary hall here. And that session, the chair will be Dr. Adomora, the UNFPA rep. There are several presenters, and they will discuss population size, growth, and age structure. The next session will be on fertility. The sub-team now will discuss family planning, affects for Kenya's development agenda. And the chair will be Professor Richard Muga. Professor Muga, some time back, he was also the chair, the DG for National Council for Population and Development. There will be a group of panelists and presenters for that session. Then we have what the sub-team, the team on mobility and mortality, where we move to sub-team 3.2, where we discuss mobility and mortality among adolescents and young people. This session will be chaired by Dr. Sheila Macharia, and there will be also a number of presenters across the session. Then the fourth session this morning, breakaway session, will be on migration, mobility, and the urbanization. We will discuss something 4.2, which will be on international migration. And we are privileged this morning. The chair will be Charles Nyao, the Deputy Director of Migration and the Secretary of the National NCM. Then the last session for the breakaway will be on population and humanitarian settlement. And the chair for this session will be Professor Edward Murugu, who is a professor of sociology, faculty of arts, University of Nairobi, and they will be presenters. All of these breakaway sessions will run up to 10. Then we'll have a 10 minutes break where we will transit to the next set of breakaway sessions, which will be running concurrently. So when we reach that time of break, you will be request you to move and choose the session which you are interested, which maybe you also registered, so that we transit to the next set of sessions, which will be running concurrently. After the second set of concurrent session will also continue on population size and growth and age structure. We will discuss subtheme 1-3 on the vulnerable population, orphan and vulnerable children, the elderly, persons with disabilities, and also displaced persons. This session was chaired by Mr. Nicholas Kitua, the Director of Planning in the State Department for Social Protection, and there will be a set of presenters give the insight and then discussion. The second session under fertility, session 2.3. Now we will narrow to marriage, child marriage in particular in Kenya. This is a very important session for us, which we need to discuss. And Professor Onyango Ouma, the Director of Institute of Anthropology, Gender and African Studies, University of Nairobi, is the one who is going to moderate this session, and there will be a number of facilitators for that session in your friends, readers in that debate, supplement area. It is very important. Then the next theme 3 on mobility and mortality, subtheme 3.3 will focus on adult morbidity and mortality, and this session will be chaired by our Cabinet Administrative Secretary, Dr. Mazi Mwangagi, Minister of Health, and we have already that session, as I mentioned, it will be streamed also live. Then on theme 4, migration, mobility, and urbanization, we move to subtheme 4.3, where now we'll discuss the issue of urbanization. We had yesterday's plenary. Kenya is rapidly urbanizing, and we need to take attention to the rapid urbanization issues. And this session will be chaired by Honorable Alex Mwiru, Cabinet Administrative Secretary, Minister of Finance and Fiscal Planning. Then in this concurrent session, the fifth session will now move to theme 6, where we focus on data, innovation, and research. And the first subtheme 6.1 on data and research. The Director of Social Governance Directorate, State Department for Planning, Mr. Waweru Kamau, will chair it. After that set of session, we will also have a break of 10 minutes to assist us transit to the next concurrent sessions, which will also run up to 1:10. We will continue theme 5 on population and human settlement and the environment. Subtheme 5.3, now we look at hazards and the risk responses. And Dr. Duncan Cheng, Director, National Disaster Management Unit, will chair this session. We also continue the theme 6 on data, innovation, and research, subtheme 6.2, where we will discuss now issue of innovation and the data availability. And the Director for Monitoring and Evaluation Directorate in the State Department for Planning, Mr. Royce Rastemu, will chair that session. And then we move to another theme, which is also very important in the population policy and the environment. Theme 7, education and training. We have a subtheme 1, 7.1, where we discuss a lot of education and training in harnessing the demographic dividends. And this is a session where the Chair National Council of Churches of Kenya, Secretary General, Reverend Canon Chris Kinajui, will chair the session and present the presenters. It's a very important session for us. I have realized the youth. Yesterday, we use the primary issue of the youth structure of our population, we need to have measures in place to harness their potential. Then the last session on this conference set will be Team 8, which is very important for us, on resource mobilization for the population program. And the first sub-team towards availability, public and the private sector resource mobilization for the population program. We are going to our Honorable Engineer Mark Nyamita. Then before reading, we is also the first year of the Parliamentary Network on Population Development GRT session, and there will be several presenters who will share our experience. And in this session, our chair, the National Council for Population Development, Honorable Bertie Gugi, is the one who will introduce the panelists, the chair of the panel. And you indicated yellow so that it will be streamed live, and you can see we have a panel of panelists who will give just that topic. After we go through all those, we have proposed, we now refer to the plenary at 1:10 to enable us wrap up and end the day. We see you to the operation today. We will be guiding you whenever there will be an issue. I request now we move to our breakaway sessions so that we can start the sessions. Thank you.
Good morning. Good morning. Can you hear me?
Yes, we can hear you.
Louder.
This is the fourth panel. Distinguished panelists, delegates, and participants. My name is Charles Munyao. I'm the moderator for this session. I'm
Hello?
the deputy director. Hello.
Which session are you moderating?
Fourth session.
Fourth, you have to go to the breakout room. That is the session.
Okay.
Hello, Sarama. Niko salama. Okay. Niko salama pia. Okay.
Yeah.
Oh, okay.
The breakout rooms are not activated yet.
Oh, kwanza hapo zaidi.
Unajua daktari hakuandika time sasa, unajua.
Hakuandika time. Zote tumeona.
Hakuandika time sasa.
Saa 6.
Sasa mimi nikasema bila kuandika time moja iko tu saa 3.
Okay, can we go to the breakout rooms, please? They're activated in the 4 squares on the bottom. Morning, ladies and gentlemen. We are going to give people about 2-3 more minutes for them to migrate to the various breakout rooms before we go on with this first sub-theme, which is that sub-theme that will be discussing age structure. And so if there are people still online who would like to join other breakout rooms, this is the time to do so before we start on this one. So in 2 minutes, we're going to kick off on this session, and we hope that we will be able to do justice by 10 a.m. as proposed. Thank you.
Good morning, Ademola. I have a question. I'm trying to join the International Migration Breakout Room, and for some reason I can't get in. So I don't know what to do on my end. Is there a technical person on board that can assist me?
I'm sure they're listening right now.
Okay.
Can you put it in the chat?
Okay, thank you very much.
Technical people on board. So anybody who's got challenges joining any breakout group, should please put it in chats, and there are people who will help them make that move. All right. Once again, good morning, ladies and gentlemen. Yes, so we can see that the technical colleagues are addressing, and they will be happy to help you. And while that is going on, it's my pleasure to welcome everyone to this what will be a very interesting conversation. And we're going to be talking about age structure and development. As we heard Mr. Nyakwara say in the morning, the theme for this morning session is population size, growth, age structure, and vulnerable populations. And the sub-theme for this breakout group will be age structure and development. And my name is Ademola Olajide, and I represent the United Nations Population Fund here in Kenya. And I do look forward to interesting conversations that we're going to have this morning. Just again to respond to say that for those of our colleagues who are having challenges getting to the breakout groups they want to, just put it in the chat box. There are colleagues who are working on that, and they would help us do that. Thank you. And so this group, we're going to be discussing age structure and development, and we do hope that by the end of that conversation, we'll be able to present for us a trend of Kenya's changing population age structure at both national and county levels, discuss the implications of this changing population age structure on national and county level development, as well as make recommendations that can help Kenya harness the potential benefits of that age structure. As we know, the age structure of any population has significant implications on production and consumption patterns because of different needs of people based on their age. Of course, this is also used in some instances to determine allocation of resources at county level and for the purposes of achieving the best outcomes. The 2019 population and housing census, which enumerated Kenyans at 47.6 million people, presented for us a picture that showed us that 39% of this population were children below the age of 15, while 6% were older persons above 60. Those in the working age of 15 to 64 made up 57% of the population, while youth 18 to 34 accounted for 29% of the population. Women of reproductive age are half of the numbers of females in the country. So it therefore means that our age structure has to be thoroughly understood in a way that would allow us allocate resources, design interventions such that we will optimize development from this structure. For me, yesterday was very interesting and pleasing to note that we could have my teacher and very senior colleague, Professor Kamarogo, facilitate the first session, even from his village. And that is instructive. Because as they say from my own village, that even though a hunter may not be able to go into the forest to hunt as a result of age, he may still contribute to the training of young hunters by virtue of experience. And so we were able to deploy technology in a way that helped us to harness the experience of Professor Kamarogo, despite the fact that he was in the village. And so this morning, we're going to be discussing our population age structure to the extent that we'll make concrete recommendations that will help us optimize it for national development. And we have three quite experienced discussants this morning. We have Mr. Francis Kundu, who is the Assistant Director of Population at the National Council for Population and Development, with an academic background in statistics, computer science, and demography. Currently, he works in the Program Coordination Division of the NCPD and is in charge of international and national development agenda, also serving as a focal point for population health and environment program. He's been involved in research, policy development for at least 15 years and has worked at various times at different counties as a policy officer. So it brings to the table a rich array of experience, not just in research and policy formulation, but also on the ground. And so we look forward to listening to Mr. Kundu. We also have Ms. Colette Alo Obonga, who has a master's in population studies and demography from the University of Nairobi, and with a rich experience spanning over 2 decades in population and reproductive health policy, planning, and advocacy. She's worked in reproductive health program design, management, and research, particularly focusing on adolescents and family planning programming. She brings a reach of experience that involves both government, non-governmental, and the private sector, and has since 2011 been working as a consultant for the Population Reference Bureau. And so she brings to the table a rich knowledge with regards to population, demography, reproductive health, adolescent, sexual and reproductive health, both in the policy formulation component as well as in research. And so we look forward to also listening to her and learning from her experience. And last but not the least, we're going to be listening to Dr. Bernard Onyango, who is a senior research and policy analyst from the African Institute for Development Policy, AFIDEP, with an extensive experience in the field of population and development. His recent work has focused on providing technical expertise to various governments and development partners on demographic dividend across Africa, including the identification and implementation of policy options to empower women and youth to harness that dividend. He obtained his doctorate and master's degrees in sociology, social demography, and urbanization from Brown University, and is a member of the Union for African Population Studies, International Union for Scientific Study of Population, and the Population Association of America. So ladies and gentlemen, this morning we are going to be having a rich conversation. And so may I also plead with the presenters, let each of us manage our time, including myself, to 10 minutes, so that we can take conversations from the participants and enrich our conversation. If we cannot manage our time, I doubt if we can manage our population. So we look forward to a very rich conversation, and I invite all participants as well to use the chat box. So if you've got questions, if you have recommendations you want to make, please use the chat box. And so it's my pleasure at this point to invite Mr. Francis Kundu, who will start us off and take the first stab. Mr. Kundu, over to you.
Okay, thank you, Chair, for that introduction. So I'm going to make a presentation on the trends in Kenya's population age structure over several years. And we'll be able to look at this presentation in terms of what is happening at the national level and also what is happening at the county level. So we look at the trends at national level and also at county level. And specifically, we are going to look at 3 age groups. That is children below the age of 15, those in the working age population, and then the older persons. So we want to see how the trend is like, both at national and county level. Now, this is just an indication on what has been happening in the population. The population of Kenya has been increasing over the years. From independence up to 2019, the population has more than quadrupled over that period. But as we have been having that increase, there's also been changes in the age structure, and that is what we want to be able to see. Now, looking at this slide, it shows what has happened in those 3 age groups that I mentioned. You can see the blue line there, that represents children below the age of 15. You find that in 1969, there were 48% of the population. And this was more than those who are in the working age, that is age 15 to 60, that is 46% were in that particular age bracket. But what has happened to these 2 groups over time? If you look at 1989, you find that these 2 groups were almost the same in terms of proportion, at about 47%. But after that time, coming to 2019, you can see there's been a difference. Now we have that those who are age 15 to 60, their proportion has increased from 1989, and it's higher than those of children below the age of 15. So that from the 2019 census, we find that those who are 15 to 60 years are 55% of the population, while children below the age of 15 are 39% of the population. And when you look at this, we are saying that this is good, especially for demographic dividend, because the dependency levels are coming down, the proportion of children is coming down, but those in the working ages who really need to transform the country socioeconomically, that proportion is increasing. Now, the line at the bottom there shows the elderly persons. In this particular case, those who are 60 plus, and you can see in 1969, there were 5.4% of the population. Then this figure went down to about 4.6, 4.8, 4.7, but currently it is at 5.8%. So in terms of national level, this is the trend in those three age groups. Now, with those changes in the proportion of those three age groups, this pyramid is showing exactly what is happening. So in 2009, from the census results, you can see that our population pyramid was more or less like a perfect pyramid, with the bottom being, the bottom bars being the longest, while those at the top being much smaller. But when you look at the 2019 pyramid, it's a bit different, because when you look at the bottom, you find that the bars there are shorter compared to those who are 10 to 14 years. So those who are 0 to 4, the bar is shorter. Those who are 5 to 9 years, it is shorter. So basically, this means that we are getting fewer children into the population. And again, this is good for demographic dividend. Now, this one is just showing what has been happening in terms of the total fertility rate from a high of almost 8 children per woman in 1978. And the last estimate, that's 2020, it's about 3.5 children per woman. And now this supports what we have seen in the pyramid there, that actually we are getting more children. This is because the fertility levels have gone down over time. Now, this shows the counties. Now we have moved to the counties. Now we are looking at the counties, and we are looking at the counties with the lowest proportion of children below 15 years, because we are interested that this proportion of children actually comes down to about 30%, and that will be conducive enough for demographic dividend. Now, when you look at this chart, it shows that Kirinyaga, Nyeri, Nairobi, and Kiambu are just at about 30%. Are children below the age of 15. So we can say that for these counties, it's like the demographic window of opportunity for them is opening up. Now, on the other end, we have counties such as Samburu, Wajir, West Pokot, and Mandera, where you find almost half or more than half of the population is made up of children below the age of 15. So for these counties, again, when you're talking about DD, they still have more work to do to bring down this proportion of children so that they're able to reap from the demographic dividend. Then looking at the working age population, this is the working age population. So it shows here that counties like Mandera, West Pokot, Samburu, and Wajir, less than half of the population are in the working age. While on the other end, you find Kirinyaga, Kiambu, Mombasa, and Nairobi, almost 2/3 of the population is actually in the working age. So for these counties, if this proportion of the population is able to get opportunities to work and to be productive, then it means these counties can really move ahead socioeconomically. Now, this one is showing counties in terms of the proportion of the population that are older persons, in this particular case, 65 years and above. And you can see Nairobi, Mandera, Wajir, and Garissa, the proportion is low, less than 2%. And in Nairobi, we could understand that those people who are getting older and are retiring, most of them maybe would prefer to go and live in their rural homes. But for Mandera, Wajir, and Garissa, the proportion is quite small. On the other hand, the counties with the highest proportion of older persons are Murang'a, Nyeri, Vihiga, and Tharaka Nithi. So looking at this, maybe questions may come. Is it that maybe in these counties with the highest proportion of older persons, maybe the quality of life is much better, people are able to live longer, while in these other counties, maybe it's the opposite? Or is it because of the high fertility so that the proportion of children is really high, and therefore when you take the proportion of older persons, you find it's quite low? So this is just to give an indication of what has happened between the 2009 census and the 2019 census. And here we are looking at counties which experience the highest decline in the proportion of children. And you remember we are saying that this is good for demographic dividend. So we find Makueni is the one which had the highest decline at almost 8.8 percentage points, followed by Kitui at 7.5, Nyandarua, Machakos, and Embu. So we are seeing a fast decline in these counties in terms of the proportion of children below the age of 15. While at the same time, if you look at counties like Isiolo, Mandera, Marsabit, and Nairobi, from the last census, it showed that there was actually a slight increase in the proportion of children below the age of 15, although the increase was less than 1%. Now, this one shows counties with the highest increase in the proportion of the working age population. And this is the population that we need to be able to work and drive our economies. And again, you find Makueni is the one which had the highest increase at 7.3 percentage points, followed by Kitui, Nyandarua, Machakos, Nandi, and then at Embu at 5 percentage points. And at the same time, you find that in Mandera and Nairobi, these counties actually experienced a slight decline in the proportion of those in the working age. So this means that apart from these counties that I've highlighted here that experienced an increase, all the other counties in the country experienced an increase apart from Mandera and Nairobi. Then finally, in terms of the older persons, here we find that the counties which had the highest increase in the proportion of older persons, this is Tharaka Nithi, 1.8 percentage points, Makueni, Nyamira, Nyeri, and Vihiga. At the same time, in Garissa, Isiolo, Kajiado, Kiambu, Marsabit, and Wajir, these counties actually experienced a decline in the proportion of these older persons. So in a nutshell, this is how the trends have been in terms of the proportion of those three age groups, children, as well as those in the working age population and the elderly persons. Thank you, and over to you, Chair.
Thank you very much, Mr. Kundu. This is quite an interesting presentation. And as you can see from what you have told us, there's been, of course, changing trends with regards to the age structure of the Kenyan population. We saw an increase in terms of the population in absolute numbers, and we saw how the trend varied from county to county, and how that especially affected the dependency ratio and the capacity of the nation to put in place targeted interventions that can help us really harness a demographic dividend. We also saw the changes with regards to the older population. And so this is beginning to tell us that we cannot have a one-size-fits-all. We cannot have interventions that can just be uniform or blanket. It has to be targeted to those age structures. It has to be such that we can utilize the trend to facilitate development. Thank you very much, sir. That was a quite interesting and insightful presentation. It's my pleasure at this point to invite Ms. Colette Alo-Obonga, who is also going to give us her perspectives from what she has experienced, and she's going to take us also into the conversation looking at the implications of Kenya's changing age structure. Colette, over to you.
Thank you very much. All protocols observed. This is
Can you speak, Colette? I'm not sure we can hear you properly. Maybe you need to move closer to your system.
Oh, let me also increase the volume.
Colleagues, can you hear properly? Ezekiel?
Can you hear me now?
It's still low.
It's
The
still
voice is low.
It's
faint.
still low.
Very faint.
Aha, now it's very faint. You might want to move closer to your system.
Okay, can you hear me now? Can you hear me?
It's faint, we can hear, but it's faint. There was something you did a few minutes ago, made it better.
Because the volume is fairly high.
Maybe you speak louder. It's coming across, and then we hope we'll be able to catch up. Thank you.
Let me speak a little bit louder.
Yes.
So I'm going to talk about the implications of the changing age structure. Can you see me?
Yes, we can. We can. Very well. I'm now going to take us through the implications of the country's changing age structure. And next, Ezekiel. So basically, I'm going to introduce the subject matter and then look at the age structure at a glance. But the main thing will be implications of our changing age structure. I'll talk briefly about the youth, the working age population, and the elderly, and then move to conclusion. Next. So as a way of introduction, I want to say that age structure of any population, whether it is Kenya or any other country, has an implication on the production and consumption patterns because of the different needs of the people in the population based on the current age structure. Therefore, the changing age structure of any population will always have significant socioeconomic implications at many levels, whether at individual, at family, at community, and at societal or national levels, including a country's development. Changes in age structure can also enable a country to gain from the demographic transition, given the right socioeconomic policies. And I think my other colleagues will be talking a lot more about this, and we also started hearing about it yesterday during the plenary. And therefore, a population's age structure deeply affects development opportunities and plays a major role in security and governance challenges. Next. This is just to look at an example of population pyramids where we have high fertility scenario and low fertility scenario. And Francis already shared Kenya's population pyramid in the 2009 census and the recent 2019 census. And we saw how in 2009 we had what was called what we heard yesterday from a presenter called childbirth. Now we are moving into a situation of youth birth, where the number of children less than children less than 14 years are becoming less. And Francis also showed us some counties that are already experiencing that. So we are saying when we look at the population pyramids, that the population's growth rate is strongly influenced by the proportions of individuals of particular age. So
the age structure has a greater, the age structure that Francis shared has a greater proportion of younger individuals who are at or close to reproductive age. And that is what we are seeing in the pyramids that I'm sharing. And in 2019, with the fertility rates declining, starting to decline in Kenya, we start witnessing youth bulge. And as we heard earlier during plenary yesterday, this is the stage at which a country should start reaping from the youth bulge or from the demographic dividend. Next. So we are still on the point of the growth rate of a population that strongly influences the proportions of individuals of particular ages. So with knowledge of age structure, the population growth can be more accurately predicted. When we look at the age structure of the population, we can easily start talking about the future, predicting the population growth rate. And Kenya's annual population growth rate was estimated at about 2.2% in 2019, which was down from 2.9% in 2009 and 3.8% in 1979. This shows a decline in growth rate over the past 4 decades, which is a good thing. However, population size continues to increase and is expected to continue increasing in the coming decades. So even as we experience population growth rate decline, the population in terms of numbers will continue to grow. And this is because the country has a youthful population, with nearly 40% being 0 to 14 years old, and therefore the population, there is already a momentum for population growth which has been put in place. At the same time, we can see that the females in reproductive age, that is 15 to 49, are half of the total female population. And this has a very, very significant impact on the country's future fertility levels. And again, the momentum for growth is already in place. The working age population, which makes up 57% of Kenya's total population, is also expected to increase in both size and proportion because, as I said earlier, the momentum for this growth has already been put in place, as explained above. The 60-plus-year-olds are the fastest growing segment of Kenya's population, from about 2 million in 2009 to 3 million in 2019. And this is very, very significant, as we shall see later, for our development and for other strategies or interventions that need to be put in place. Next. So now let's talk about the implications. So changes in a country's age structure can have significant effects on its economic performance. Let's look at this table. On the left, we have the population age structure. On the right, we have the effects on the economy. If we look at the first row, high proportion of children, 0 to 14, what would be the effect on the economy? It means that we will need high proportion or a lot of resources for care of children, especially for their health and education. Because we know that in Kenya, early childhood is characterized by so many threats, such as common childhood diseases, hunger or overnutrition, child neglect, and inadequate nurturing and care. And the next row is high proportion of working age population. This has an effect of added productivity of this group, which can produce demographic dividend of economic growth if the right policies are in place. That is, policies to do with health, financial allocations, and labor and human capital. So Kenya's youthful population calls for very heavy investment in health and education so that we secure their well-being, they become productive at working age population of 1564. Now, when we look at the high proportion of elderly persons, that is age 60 plus, what is the effect that they would have in the economy? Large share of the resources will be needed for a relatively less productive segment of the population. They will need healthcare, they need pension income, and other areas of social protection. So fast growth of this population segment in Kenya has greatest implications on social protection measures. This is more so because they are the poorest age group in the country, with even more than half of them living in absolute poverty. So an aging population tends to lower labor force participation and saving rates and may slow economic growth. At the same time, there are certain health conditions in this age group that are expected to be a challenge to our healthcare system, with the increasing aging population, cancers, obesity, cardiovascular diseases, diabetes, dementia, etc. Therefore, age structure data will allow the rate of growth or decline associated with the population's level of economic development. That is what that table is talking about. Next. When we turn to the youth, herein lies the source of labor supply. So one to recall that the AU agenda, AU Assembly, the African Union Assembly decision in January 2016 established the theme for 2017, harnessing the demographic dividend through investments in youth. And we heard a lot about this yesterday during the plenary. The AU heads of states and governments recognize at the country level demographic dividend is central to the continent's economic transformation in the context of the AU Agenda 2063. Just to say what this is, AU Agenda 2063 is, it is a global strategy for socioeconomic transformation within the next 50 years. African frameworks provide insights on what policies support a demographic transition and also outline strategic investment. Adolescents and youth have the right to be healthy, attend school, and to be empowered with the skills they need to be economically productive. So a demographic dividend can occur during a window of opportunity created by reductions in child mortality and a demographic shift to fewer dependent people relative to working individuals. Next. Continuing with the youth, 70% of Kenya's population is below 30 years, and their numbers are continuing to increase. Therefore, youth should be one of the main economic assets for a country or a region, because it continuously feeds our labor market, and their numbers present an opportunity for faster economic growth. So when labor force growth rate is higher than available jobs, high levels of unemployment is experienced. And probably this is what is happening right now. Labor force growth rate is higher than available jobs. In Kenya, about 13 or nearly 15% of our youth 15 to 34 are not in employment. They are not in gainful employment, or they are underemployed, or they lack adequate, the issues are lack of adequate education or training, and many issues are to do with education and training for skills acquisition and employment. And then we find ourselves in distress migration. Our youth are migrating not because they want to migrate, but because they are forced to migrate to look for opportunities in cities and other urban areas. Now let's go to the working age population. This represents 60% of Kenya's population, and again it is also continuously fed by the youth. The demographic dividend can only be reaped through sound policies to ensure adequate education, skills, and assured jobs, so that these young people, the large waves of young people can enter labor market when they are adequately trained, educated, and they are skilled, and jobs exist for them. Therefore, the magnitude of economic growth depends on the capacity of the economy to absorb additional workforce. We know that the main issues for this population age segment is, as I said earlier, inadequate skills, untapped skills, skills mismatch, access to decent work, preference for white-collar jobs, lack of access to credit facilities, long-term unemployment and underemployment, and labor inactivity. And I think the next speaker will be talking more to this. Therefore, we find that education, training, health for both men and women, and a well-functioning labor market are prerequisites to reap the benefits of the demographic dividend, which would be powered by rise in human capital, rise in labor supply, rise in savings. Next. In conclusion, therefore, depending on a country's politics and economy, youth may become an economic asset or a potential factor of instability. So while youth are Kenya's greatest untapped natural resource, they can also be the country's greatest risk. For example, lack of economic opportunities is a key driver of radicalization, unrest, and violent extremism. Therefore, both national and county governments can no longer ignore age structure in planning and resource allocation. And yesterday we heard that we should now not plan for population, but plan for people. And people means that we need to take each age segment at their needs. So when we are calling, therefore, on the national and county governments to invest in health of families, including reproductive health and family planning, to invest in education for the 21st century because this will ensure youth can go to school, they can stay in school, and get the skills to succeed in the 21st century. The government at both levels should also provide work opportunities for our youth to be employees, not just to be employees, but also to be employers, and also ensure inclusive and accountable governance, which will make Kenya a country our youth want to be part of. Next. Thank you very much.
Thank you very much, Colette. Thank you so much. You have again reminded us that the changing age structure within the population is very key with regards to implications for production patterns, for consumption patterns. It has significant socioeconomic implications. It also has a clear impact on the development opportunities that the economy has to grow. And it is important for us to begin to look at that link between that population age structure and international migration, the search for better opportunities, for job production, for economic performance, and for us to ask ourselves a critical question. Are we going to be harnessing a demographic bonus, or are we sitting on a demographic bomb? It therefore is important for us that we need to understand that for every single country, this is important. You mentioned the African Union and the theme for 2017, which was harnessing the demographic dividend. Incidentally, I was head of health for population at the African Union at the time that theme was being conceived. And what drove the message home for Africa was the Arab Spring. it was very obvious for African leaders that the things we were seeing in the Arab Spring of 2011 had a direct correlation with the population age structure of those countries and the lack of opportunities for the young people, which created an enabling environment for the chaos that ensued. And so it is important for us to understand that what we have to do is to optimally harness a demographic dividend, and so that we benefit from our changing age structure. There's a question for you which we will come back to, which is there any advantage if we continue to have increasing proportions of people over the age of 60? That's an interesting conversation. But at this point, it's my pleasure to invite my friend, Dr. Bernard Oyango, who is going to take us through what we have to do to avoid that demographic bomb, but also to ensure that we harness a demographic dividend, that we reap optimal benefits from our population age structure. Bernard, over to you.
Thank you, Dr. Ademola. Thank you, everyone, for giving me this opportunity to speak at the conference and share some of my thoughts. So my presentation is going to build on the first two and focus on priorities for Kenya to harness the benefits of its changing age structure. And I hope, Dr. Ademola, I hope you can all hear me well. Okay, thank you. I'll just start by, again, going to our pyramids, and I want to move on this very fast since we've already looked at this. And just to note that we are beginning to see that change in the age structure where we are having fewer children and more people within the working ages, so that we'll eventually have the working age bulge. And as Francis had already shown earlier, what we need to take note of as a country is that while this is the national picture, in fact, there is quite a bit of variation when you go from county to county. But importantly for me, I think, is really to recognize that 75% of Kenya's total population, as per the last census in 2019, is under the age of 35 years. Okay, so when we are talking about every 100 people in Kenya you'd meet randomly, 75 of them are under 35 years of age, and 39 of them are under 15. So for me, the important thing is to understand that even as we talk, when we are talking about priorities, we should also look at where should we focus, understanding that this should be a life course approach, where we look at what we need to do for children, what we need to do for young people, and people at the older ages. But very importantly, if you look at this from a life course perspective, then you understand that for us to really harness the demographic dividend, one, we have to make investments in children who are the future. We are talking about 39% of the population now. We have to make investments in young people. If you think about it, 15 to 34. Someone is, excuse me, I think that's.
Bernard, unmute yourself now. Bernard, please unmute yourself.
Okay, thank you. So we have to think about that life course approach. But the important thing is that this demographic dividend, will be an illusion if we don't make those required investments starting really today. We don't have the time. And I think the World Bank has, really come up with this human capital index, which is a very important way of thinking about how the kind of investments you have to make. And the human capital index is asking the question or measuring, will children born today survive to school age, one? And for school, how much will they complete and how much will they learn? And finally, we are looking at health. Will they leave school in good health and ready to learn and work? So will they be productive once in the working ages? So it's important, if you can see that chart, this is a ranking of the countries in the world where they've looked at the human capital index. And on the y-axis, you have the human capital index, which is from 0 to 1. You can see that Kenya is really at sort of at the middle of the pack. Probably, I'd say probably a little less, but I'd say middle of the pack. When you think about probability to survival to the age of 5, 96 out of every 100 children born in Kenya today are going to survive to age 5. In terms of expected years of schooling, it's measured that about a child who is at age 4 today can expect to complete about 11 years of schooling by their 18th birthday, which is somewhere, I'd say, at secondary school. But once you factor whether learning is actually taking place, then the expected years of schooling is only 8.5 years, which for the current system is just, I'd say, Form 1, just starting of, Form 1 education, yeah. The adult survival rate across the country, 77% of those who are 15-year-old are expected to survive until age 60. But importantly, 26 out of 100 children today are stunted and 4 at risk of cognitive and physical limitations that can last a lifetime. So remember, that was an important point that came up yesterday. And I just wanted to drop in a bit about the COVID-19. I think COVID-19 has, in terms of the burden on mortality and morbidity in Africa, has not been as high as some of the other world regions. Partly also, we are not testing enough. But the long-term implications of COVID-19 are going to be very important for our populations. And investments in education, employment, and empowerment have been seriously affected by COVID-19. And so these are areas where we'll have to think about COVID as it's an episode, but something that can also happen. So we have to recognize that, progress is not always in a straight line, and things like COVID can come along and affect progress. Yesterday, you saw this chart. Again, just thinking about the youth aged 15 to 34 who are not in education, employment, or training. Currently, in the third quarter of 2020, a total of about 2.7 million people in this age group were not in education, employment, or training. And as you can see also from that chart, these numbers also increased post-COVID. So some of the drivers of the demographic dividend under threat and exacerbated by the COVID-19 include health. We've seen a spike in teenage and unintended pregnancies. We've seen people losing jobs. So the UNECA, for example, estimated last year that 19 million could lose their livelihoods. And 29 million pushed into poverty. That's looking at Africa as a whole. And a lot of education-wise, we know that education and training was disrupted, and as a result, we've had a lot of dropouts. But even importantly, as people are trying to adapt to these changes, it also seems that the vulnerable groups are at risk of being left behind with the deepening inequalities. For example, when we tried to move on to online training, we realized that large parts of the country, and especially in rural areas and the urban poor, don't have access, for example, to the facilities we have here, where you can have an online training going on. So I'll now move to the priorities. So under health and well-being, it's important really to provide comprehensive sexual and reproductive health and rights and voluntary family planning services, especially for adolescents and young people. And we've seen that, for example, when you look at teen pregnancies in this country, there's been very little progress over a very long period of time. So it's one of those areas where we need to check. And we know that most of the pregnancies happening in these young age groups are unintended, but have serious long-term consequences for those young people, including curtailing the education and even the opportunities for work. Improving maternal health. Again, our maternal health outcomes, though we've had interventions, are still not where we want them to be. So in this day and age, we should not really be having women dying in childbirth. And while people think that this is just a rural problem, actually, when you look at the data, even in urban areas, people going to hospitals are still also having some bad outcomes when it comes to maternal health. Investing to improve food security and nutrition, another critical area, but also eradicate and halt the infectious diseases such as malaria and HIV/AIDS. We've been seeing progress, but still the burden of both morbidity and mortality from these communicable diseases is too high. But then also addressing the rapidly increasing burden of non-communicable diseases, including increasing incidence of mental illness, and designing effective interventions really to reinforce the adherence. So we have the laws, but the adherence to existing laws to protect girls and women, especially from sexual and gender-based violence and harmful traditional practices such as female genital mutilation and child marriages. So next slide is on education and training. So we've already seen there's been quite a bit of work done towards improving access to primary school, to secondary school. So we have the free secondary education program, for example. But we are seeing that, learning outcomes are not optimal. And so there has to be a focus on improving those learning outcomes for education quality and skills acquisition, so that once people out of the training pipeline, they're able to be productive. Implement strategies to halt the school dropouts, and especially for some disadvantaged groups, especially girls, those in rural areas, urban poor, and people living with disabilities. And embracing, we've seen, and COVID really sharpened this, embracing technology for education while addressing those challenges that could feed to rising inequalities out of these adaptations. So employment, as we've seen, really large pool of young people who need to be employed, who are out of work. We need to understand, adapt, and adapt to the future of work, which is changing very rapidly. And invest in the informal and gig economies where a lot of these young people are involved in, but also provide when it comes to social protection. We talked about, the previous speaker talked about, the growing elderly population. So we are putting in place some social protection programs, but we need to make sure that these are inclusive and evidence informed, and deploy evidence-based targeting of such programs. And in addition, we have to monitor and evaluate the impact of these programs so that make them effective. We need a data revolution in this country. I think that there's really no question about that. One of the challenges that counties are struggling with is that they don't have the information, at county level to enable them implement effective programs. So we need to strengthen routine and survey data collection. When you look at this country at times, for example, you find a lot of data in the area of the health sector, and then probably in education. But once you start going to other critical sectors, the data is a bit, it's scarce and it's not disaggregated. So we need to have a way to make sure we collecting disaggregated data, be it by sex, looking at different levels, so that you're going to even the small areas. We know that in this country we have the ward fund, which the MCAs run, for example, and those need to be informed. How they target that money needs to be informed by evidence, right? And then obviously I've already talked about monitoring, evaluation, and learning to improve effectiveness of programming, and promoting the use of alternative data collection and evidence generation models. So that, for example, during the COVID period, we were unable to conduct some of the traditional surveys that we've had, but we've seen some, progress in terms of people thinking outside the box and being able to collect data. So I'm going to skip over this because I've already touched on it, but just to note that these digital technologies, if you're able to leverage them, we can improve, for example, our health services, we can improve education, but also in the area of employment. I just wanted to put this out on environment and climate change. This is a big issue for the next, the next decade and the next few decades. And we have to look at it. I think the problem has been that most of our action on this has been in terms of responding to emergencies. We have to look at it in a three-pronged approach where we are doing mitigation, investing in mitigation, investing in adaptation, and investing in building resilience of communities to be able to deal with climate change. And finally, we have, building on the strength of multi-sectoral action. So cooperation, for example, between the national and county governments on population and sustainable development, Kenya will have to work, the national government and the county government will have to work together, but also leveraging those regional integration and continental collaborations and partnerships and sharing best practices and learnings from programs in other countries. So, with that, I'm going to stop there. My last slide was just to show the issue around the inequalities, which I've already touched on, and so I won't go through that slide. Thank you.
Thank you very much, Bernard. Your presentation is one of those kind of presentations that continue to challenge us in the way that we should take action to ensure that as a nation, we get optimal benefit from our population age structure. One of the things you emphasized so much was the fact that it must be a life course approach, which means that whatever interventions that government puts in place and all stakeholders must be targeted for the entire life course and must be tinkered with to apply to each individual age bracket. And of course, like you said, we must start today, but not necessarily today. We should have started yesterday. And unless we do that, we will not be able to get to those things we want to do. The Human Capital Index continues to remind us that population is not just about numbers, it's about people. The quality of their lives, the quality of their background, the quality of interventions that we put in. One thing that caught my attention was the fact that you talked about the cognitive function, particularly as it relates to children, stunting. In 2013, the African Union launched what was called African Regional Initiative for Stunting Elimination, ARISE. And at that time, what we noted was that there was a significant economic cost that African countries were losing without knowing as a consequence of childhood stunting and undernutrition. It was not allowing children to grow to their optimal capacity. And even when they became adults, they were not productively contributing to the population. And so it was important that we continue to ensure investment in a way that addresses child nutrition, reduces stunting, and ensures that we have significant proportion of young people in education, in employment, in training. So we've seen that what needs to be done needs to be multi-sectoral, and that has to be a lot of intersection between counties and the national government. So we're going to go into discussions for the next 15 minutes, and I will start again with Mr. Francis Kundu. You've shown us, I'm sure Francis is still here with us.
Still here.
Yes, thank you. You've shown us the disparity between the various counties with regards to the population age structure. And I'm throwing this open to you, Francis, but also to Bernard and Colette, as well as the participants. Was there something each county did differently, or did this happen by chance? The second is there something we need to do at each of these counties differently to ensure we can optimally get each county to benefit from its age structure? Francis, in 3 minutes. Francis, did you get that? You need to unmute.
Yes, I got you. Thank you. Thank you for that question on the disparities. Now, when you look at these counties, you'll find that there's a lot of disparity in terms of, for example, the total fertility rate and also the use of contraception in all these counties. And I believe this is one of the contributing factors on why we are seeing these differences in the population age structure, because those counties with high fertility have a broad base. The proportion of children is much higher compared to those counties where the TFR is lower. And also from the 2014 DHS, we saw that some of the counties had very high contraceptive prevalence rate. That includes also Makueni, which you saw in the charts I showed, that there's a lot of things happening in Makueni. And I believe that is part of the outcome of their efforts in terms of improving family planning, provision of services, and also information in those counties. Another thing which would also be contributing to this, we know the issues of education, because education has a direct impact on the fertility levels. And you find that in those counties where the education levels are high in terms of the transition rates and also the completion rates, you find also in terms of fertility, it is much lower. And therefore you find that the proportion of children is lower. And this is mainly in the central Kenya counties. That one is coming out quite well. While in the northern counties, you find because the completion rates are not as good, and therefore you have issues to do with early marriages and also teen pregnancies coming up, then you find that the proportion of children is much higher. And this is what is causing these disparities. So for these counties where the proportion of children is much higher, they still have a lot of work to do, because somebody mentioned about the ideal composition of this age structure for achievement of DD. And what I would like to say is that what is recommended is that the proportion of children should not be more than 30%, while the proportion of older persons should not be more than 15%. So when you just look at this figure, 30% should not be, children should not be more than 30%, then you find we have a lot of counties which still have a lot of work to do in order to achieve that level. So thank you, Chair.
Thank you very much, Francis. And that actually helps us to transit to one of the questions that was asked for Collect. The question was that, is there any advantage in having significant proportions of older persons? We've heard from Francis that it shouldn't be more than 15%. So for people 60 years and older, what is the benefit if we have them in such significant proportions? Collect, are you there? Anybody else can still jump in and try and provide us some insights into this. Because for me, I have a bias with regards to older people. Because I tell people, every single one of us on this line, on this conversation, we have only two options available to us today. It's either we choose to die or we choose to get old. So whichever of those options, it is open to us. So please, Bernard, I see you have unmuted yourself, then Colette will jump in after you. Is there any benefit from all of us choosing not to die?
No, so I think the way to look at it is that aging and the numbers, even if the proportion is going to increase slowly, the actual numbers are going to increase tremendously. And as Colette had already indicated, what we know is that the quality of life of older people, they're amongst the poorest segments of the population because they've transitioned out of work and all that. So importantly, because one of the ways that people are trying to address this is to make sure there's social protection, and we have a very weak system to make sure that people are saving. A lot of these people are not poor because they were not earning. They were earning, but they were spending that money on the young people. Yeah, so it's really not their fault that they don't have the money now. But so we need to figure out how do we inculcate a culture of saving early in life, yeah, and make sure that older people live quality lives even after retirement. It's inevitable. If we don't have those kinds of investments, we are not forward thinking that population aging is going to happen, then we are going to have this double burden of having a lot of young people and old people, and so that segment of the population that is not productive but is consuming is going to grow. So that's the way we need to think about it. Thank you.
Thank you very much, Colette.
Thank you for that question. Yes, I see a few benefits of having an older population. First of all, we can say the older population is not in a vacuum. They have grown through the stages of the age structure that we are talking about. And some of them have skills. So I think mentorship, they could still play a big role in mentorship, mentoring the young, and they are custodians of certain pieces of knowledge. They could be technical, they could be cultural, the positive cultural information. And I think that should be harnessed also. And then if we were to put in place proper interventions for the older people, because everybody is moving towards old age. So it could make us as a country or even as a society to institutionalize those interventions, such that it is not, it's called what, knee-jerk intervention. Like now we are talking they are the poorest, they are the sickest. But if we were to put social protection in place, a strong social protection strategies in place, and all those other interventions, then we institutionalize those. So we make sure that as people graduate into old age, they are reaping those benefits. Then I think also maybe just from experience of, for us Kenyans who have houses in the city and homes in the rural area, I think there is the issue of less crowding and reduced stress in populated areas. So as we grow old, we tend to move back to the villages, and also we try to maybe to create protection of green spaces, especially like in the developed countries. There's greater protection of green spaces. So I think there are advantages that can be reaped from old age. Thank you.
Thank you very much. You mentioned the key thing that we also are beginning to find in a lot of African countries, in the sense that as we move towards advancing in age, we like migrating to the rural areas. And young people, on the other hand, move out of the rural areas. So as we claim that we have a young population in Africa, but in our rural areas, in actual practice, the population is more aged. So I would ask, I see two participants have their hands up. Mr. Sam Muyanga, very quickly, then I come to Ruth. Sam.
All right, thank you so much, the moderator and the panelists. There's always this thing in Africa that old age is synonymous to poverty. But that is not always true. If we increase the quality of life earlier on, the older people might even may not be dependent, especially even from a financial aspect. They might be dependent on other aspects. I have a friend of mine visited his father in the village, and he was even given transport or fuel to go back to Nairobi by an 85-year-old father, which means that if these people have a productive life, if we can increase their life expectancy and they're able to really go through some of these challenges that come with old age, then they can remain very productive. Because it is a contradiction to talk about a country working to increase life expectancy. And again, we are looking at the 65 and above with all the bad, adjectives we can describe. So that is something we need to really work on. And remember, even the superpower of the world is being led by that group, which means these are people who can still impact much more on society.
Thank you very much, Sam. I think I totally buy into that. Bernard made a point, and I think he will teach us that offline, how we can save, because I'm trying to save right now and I'm not doing very well at it. I don't know how Bernard wants us to do that. Ruth, can you quickly give us your intervention?
Yes, thank you. My intervention is around older people. I think WHO recently revised what they call older people, and there's work coming out showing that in a world of intellectualism, people in their 60s and 70s are probably in optimal productivity. So maybe as a nation, by condemning those individuals and saying they're old and poor, we are missing on a very important resource. For example, I think they would add great value as teachers in primary schools and secondary schools, bringing in a stabilizing effect. I also want to say that I believe maybe 70-80% of billionaires in Kenya are older people. So, and then I want to challenge us that we need to do more research around how are Kenyans aging. If you are doing a manual job in your lifetime, when you are an older person, you have a high likelihood of being poor. If you are working in a civil service or an executive job, and you had a problem of alcoholism when you are working, you end up poor. So I think the point I'm making is that poverty among older people is related also to the lifestyle that they lived and the opportunities that they had. Thank you.
Thank you very much. That is perfect. Before I call the next two people, I want to ask Bernard one question. When Bernard was recommending interventions, they appeared to be multi-sectoral. In fact, it was like Bernard was telling us do everything. This is the question. How can we practically help our political and policy leaders at the county level and at the national level get the right mix of interventions to address and reap this dividend? Someone asked two questions, the issue of child welfare and also urbanization. Can you fit all of that into 2 minutes? Because I'm sure political leaders have a 2-minute attention span.
So I talked about, the need for the data revolution. So we need evidence. I think the problem is, if you look at even the interventions that are being made across the country in counties, they pick on, things that look almost one size fits all. So if it is, for example, we are now talking about aging. Probably not all counties should be too concerned about aging at this point, but there are some counties which should be really concerned about aging and putting in place those measures to do that. So counties need to really be informed by the evidence. They need to generate data. And I said it's not all about surveys. Counties have the ability to use the administrative data, which they collect on a very routine basis, to actually help inform their programming. So that's what I would say about that. I think there's a question on urbanization very quickly. I think we missed that, but it's very important. One thing that's happening in Africa, there's rapid urbanization, but it's happening in a very haphazard way. So we are not really getting the benefits of urbanization that we're seeing in the global north, for example. And that means we are ending up with, rather than what we would think that urban life would improve the quality of life. When you look at where human settlements in urban areas in Kenya, the slum conditions, health in some of those places, even opportunities, then we actually, because we are not planning very well for urbanization, we are missing out on the benefits of urbanization.
All right, so thank you very much.
Thank you.
Ezekiel, 1 minute, Samuel, 1 minute, and I'll wrap up in 1 minute. This has been an interesting conversation. I see Peter telling us to wrap up. Ezekiel, 1 minute.
Thank you very much, Chair. I think we had good presentation, but connecting from the data and to what the priorities, what Bernard had given us as priorities, we need to ensure that the data that we produce go to the policymakers and planners in the format they can be able to use. I think that is where we are missing in all this. Otherwise, the information that we're producing, the data that we have of age structure will never be used unless we put it in the format that the politicians, the planners, the community leaders will be able to understand and use it. Thank you.
Thank you. Samuel, NCPD, final comment? I see your hand up. Do you still want to intervene? Anyway, colleagues, I think first of all is to thank the presenters for what has been a very, very insightful presentation and everybody who has contributed. Indeed, the age structure that we have in Kenya can serve for us as a distinct advantage if we're able to implement the appropriate interventions that are tailored to that population structure so we can harness optimally the dividend. We need to begin to see the advantages of the interventions we will implement at various times of the age structure. We must have a decisive and deliberate planning, not only for old age, but for urbanization and for providing the safety nets that would allow us as a society to optimally reap the advantage that each of our age category brings for us. Our economies must be structured as well as our political interventions around the evidence that is being presented to us in a way that we can reap the demographic dividend. It's a potential. It's a window. We have to have the appropriate vehicle to be able to feed through that window. And therein lies the challenge, as Ezekiel has mentioned. The evidence that we have, we must strengthen our evidence base. We must constantly be able to interrogate our society. How are we aging? That's a question that was brilliantly asked. But beyond that, we must present that information and evidence in a way that political office holders, policymakers, community members can use to formulate action and to formulate interventions that will move us from where we are to where we are going to be. We can make projections, and therefore we should be able to be forward-looking and deliberate in the interventions that we are taking forward. This has been a very interesting conversation that helps us look at the age structure with a life course approach. And we should take these recommendations into concrete policy action. On behalf of the NCPD, I'd like to thank everybody who has attended this session. And I do hope that as we go through the next few days, we will continue to highlight concrete recommendations that would help us deliver on that dividend that the population needs for us all to live the quality life that we desire. Asante Nisana, I'm sure we're going to be moved back as they move back all other participants into the plenary session. Thank you very much.
Thank you very much, Chair.
Thank you for a good session. So I think we hand over to Peter Yakwara at this point. Ezekiel, colleagues. Yes.
Thanks, Chair Dr. Demora. Thanks, the panelists. Thanks, all the participants who have had a very interactive session. There are a lot of things that have come out from this session, and we appreciate this rich information which is within our population stakeholders. We look forward to having a very detailed report, flagging out those issues which need policy and program direction so that we move and improve the quality of life of our population. The population structure team is very important, and we look forward to that. Now, we will have a 10 minutes break. We are waiting the other session to also move to the plenary so that we can, at the 10 past 10, we start the next session.
We return everyone to the plenary?
Do we turn our report to the plenary?
No, no.
Yes. So that we allow people to move to the next set of concurrent sessions, which will start at 10:10. Please choose your session. We will certainly give you the breakaway rooms so that you can move to your desired session. And if you are requesting that just families, please observe time so that we don't spill over to the next session. Thank you.
So they're doing- no.
Hello?
Hello?
Is this our session?
Now everyone.
Kindly note that now we are back to the hall, the plenary. We are setting the breakaway sessions. For the next 10 minutes, please reorganize and pick your session. You move in to your breakaway sessions. We are having a break of now 8 minutes. Can we pick your session as we said?
Okay, thank you. Or you have closed it? Hello?
Hello?
Professor, I was asking a question. Is the session closed?
Yes.
Session 1.
Session 1, all the concurrent session which were running between 8:30 to 10 are over. We are now transiting to the next set of concurrent sessions, which will start at 10:10. Please, if you have not finished, move to the next session. Conclude and move to the next session.
Peter, we can't see the breakout sessions at the bottom of the screen like last time. They're not yet appearing, so that we
We are
can
on break.
celebrate.
In the next,
Until break is over.
when the break is over, you will now see the session. The next 8 minutes.
All
You
right.
see now the breakaway sessions.
Thank you very much, Peter.
Thank you.
Thank you. I think we can stop it there.
Nani ekwe nani? Nzuri. Mambo?
Sauti inakuja?
Sauti bado. Mimi nafikiri bado wako kwa ile break. Wako kwa break ndio waende kwa nani?
Good morning again. The cost for the session, please don't close the sessions. Concentrate on your session only.
Not to close the record.
Don't close the live broadcast. Please fill your groups now. We have set the breakaway rooms. Can proceed to your respective session.
Excuse me. Just give me the session.
But you're not in the, we've already done the breakout rooms. You're not in this room.
We can't see the groups.
Okay, now. Once again, thank you, delegates and everyone else. This announcement from the ICT control. What we are realizing, there is an option which comes to some of us, an option of closing the breakout rooms. These are kind requests that please don't click close breakout rooms. What you have to do is just to join your assigned group and continue with the discussions. Thank you. And only record. And only what you can do, the maximum you can do is record if you are group, if you are a course.
Hello, good morning.
Morning.
I hope this is session theme number 3, mobility and mortality, sub-theme 3.3, adult mobility and mortality. Am I right? Hello, the host there. Ken Luak, are you there?
Yes.
So we're in the right room. We're in the right room, isn't it?
Yes, yeah, I'm saying that it is adult mortality.
It is adult mortality. Okay, I want to take this opportunity to welcome the delegates and the participants and the panelists to this session. This session was supposed to be chaired by Dr. Mercy Mwangangi. Dr. Mercy Mwangangi is right now, she's in another meeting, so I had to step in for her. So we have a really very rich of panelists here, and I'm going to introduce them one by one. I'm Dr. Mohammed Abdikadir Sheikh. I'm the Director General for the National Council, Population and Development. So I really I want to take this opportunity to warmly welcome you to this conference first, and also to this specific session. Our rapporteur here today is Ken Luaki, who has also all the, I think, presentations, and is going to load those presentations when necessary. But just to give you an overview of this session, ladies and gentlemen, I think we have, how many minutes like, Ken, do we have 90 minutes? Ladies and gentlemen, I think we have, how many minutes like, Ken, do we have 90 minutes?
Yes, we have 90 minutes.
So from the other side, I think they can mute their mic because it's coming with an echo. So the session objective, ladies and gentlemen, is to share the ideas and experience on implementation of policies and programs and make recommendations for addressing specifically maternal mortality, and also look at issues of emerging causes of illness and death among adults. So this is a session where we're going to look at issues of maternal mortality, but also generally, what are the causes of adult mortality in our nation? So we have the summary of, we have shared this one on the summary of this session, which is the level of adult mortality is becoming an important indicator for the comprehensive assessment of the mortality pattern in a population. The adult mortality rate often measures by the probability of dying between the age of 15 and 60. That is the probability of a 15-year-old dying before the age attaining 60. And that there is a clear differential in male and female adult mortality. Various causes of illness and adult deaths among adults have been identified, and while most of them are linked to disease burden, others are associated with exposure to risk factors. Like maternal mortality has been declining over the years nationally, but there exists a large county differentials. These sessions will enable health implementers and other actors to share experience on emerging adult disease burden interventions in places to address adults and maternal mortality and morbidity, and the existing large county differentials with regard to maternal mortality. Participants will share ideas on recommendations of reducing maternal and adult mortality rates. They will also share information on the existing gaps with regard to disease burden and deaths, and more so data disintegration based on age, gender, and the causes. The session will be 90 minutes, ladies and gentlemen. We have a session panelists here. I'm going to act on behalf of Dr. Mercy Mwangangi, who is also now in another meeting on vaccines. So our panelists, we will have an expert in population. That is Professor Alfred Agwanda. I'm going to introduce him later. We have another panelist who is Dr. Duncan Kibogong, who is the Deputy Director of Safety Programs and Education at the National Transport and Safety NTSA. We have Dr. James Gitonga, Manager of the M&E program in the Ministry of Health. This program, ladies and gentlemen, will be we're going to have a 10-minute presentation from each presenter. And then we're going to look at, we're going to have again, at least a plenary discussion and then conclusions within 90 minutes. So the plenary discussion will give us 50 minutes, but the presentations will take 30 minutes. So and then we'll have 5 minutes of wrap up. So with that, I just want to introduce the panelists one by one. In summary, let me start with Dr. Professor Alfred Agwanda. Professor I think he will introduce himself because Professor, I think he has a lot of experience in population and development, and I've worked with him very closely since I joined NCPD. I have someone I think who's a very humble professor, and I really admire his credentials. So Professor Agwanda has taught for 37 years at the various levels of formal education. He has taught at the University of Nairobi Population Studies and Research Institute for the last 28 years. He's currently an associate research professor at the Population Studies and Research Institute, University of Nairobi. On 2019, he was awarded the MBS in recognition of his role in carrying out the population and housing census in Kenya. Professor, I worked with him, I have told you, and I think we are very grateful to have him this morning. With us is also Dr. Duncan Kibonko. He is also going to talk about trends in mobility and mortality from the road traffic accident, because issues of mortality, especially adults in Kenya right now, apart from the non-communicable diseases and the communicable diseases, I think issues that is of concern is injuries and road safety. And I think Professor will also give us on that. So Deputy Director Safety Program and Education, National Transport and Safety Authority, NTSA. Dr. James Kitonga, I worked with him. He's also a medical doctor. He's a medical doctor working with the government of Kenya. He's in charge of the Department of Maternal and Child Health in the reproductive health. So let me see whether we have located our panelists. So let me start with Professor Gwanda. Professor, are you there?
Not yet. I'm getting back to, I cannot get the meeting room. Can they send the link on mail?
Okay, you are there. Now I can hear you.
You're in the right room. You're in the right room, Professor.
Professor Gwanda, you can hear me?
You're in the right room, Prof.
Okay, I can hear you.
All right, Professor. I was trying to introduce you, but that was really very mean to introduce you. So you later introduce yourself. Dr. Duncan, I can see you there.
Yes, I'm here. Are you able to hear me?
Oh, why are you someone is meeting me? The host, kindly don't meet me. I'm also the chair of this session. So Dr. Duncan, welcome.
Thank you.
Thank you, Dr. Do we have Dr. Gitonga?
Good morning, Dr. I'm there.
Yes, James, thank you very much. Thank you very much. So, dear delegates, I can see we have quite a number of participants here, around 95 participants are here. And I think this is very impressive. I think this is going to be a very interesting session. Well, we're going to start with Professor Gwanda. Doctor, I think you are hearing you had my introductions, the area that you're going to cover.
Yes.
Your area is going to be the leading cause of death among adults and measures to address the concern. So,
Okay.
Secretary, the floor is yours. You have 10 minutes. The presentation, I think, you will be projected by Ken Luaki.
Okay.
And the floor is yours, Doctor. Welcome.
Thank you.
Chair, the Professor, could you please just present from your end? I'm having a challenge doing it for your screen.
Because I'm using, let me see if you can put on the desktop. Oh, shit.
So for those who are joining us, this is the session on adult morbidity and mortality. Professor Gwanda is just trying to load his presentation. So dear panelists, you are welcome to this session, a session that we're going to discuss about what are the causes of morbidity and mortality. Looking at maternal health and mortality, what are the causes, and the other causes of general adult death in our country. We talked about issues of road traffic accident, and we're going to have an expert from the National NTSA who's going to do a presentation on that. And also we have Professor Gwanda who's going to give us the measures we're going to take to prevent these deaths. Professor, you can see you're loading. So we're just waiting for the presentation to come up. So bear with us. I can still continue giving a bit of a brief of the session as we wait for Professor to lead his session, his program. So here we're looking at issues of, someone is asking, okay.
Can you see my presentation?
Yes, Dr. You only have, we can see your, you can see your presentation, but we can just see you have you know, your desktop here, your desk. So you can see.
I'm trying to share.
Yes. Just click that part, or you have leaders conference presentation on adults.
Yeah. Then share.
Yeah, share, please. Yeah, very good. Now it is there. It is there, Professor.
Okay.
The floor is yours.
Yes, I'm trying to, because of the short sessions, I'll mention just a few key messages that we need to think about. One, the programs since the MDG and SDG has focused on that there's a strong relationship between health and development. And one key thing that has been noted is the extent of premature deaths during adulthood, particularly at young adult ages. And these results have a lot of economic implications. And about 2/3 of those premature deaths are linked to exposure to the factors such as tobacco use, unhealthy diet, physical inactivity, and so on. And a sizable proportion of such deaths are also linked to our health systems. Now, this summarizes the adult mortality between 2000 and 2019. And on the left of that, we have also change in life expectancy, which summarizes adult mortality. We have had a lot of improvements, and at current ages, by child born within the last half a decade can be able to live for about 64 years for males and 68 years for females. In 2000, this was just 53 and 54 and 55. At age 20, a boy reaching age 20 can expect to live on average 48 years, and the female 52 years. This was 40 years and 41 years in 2000. But there's one noticeable fact. If you look at age 60 and age 80, in age 80, the life expectancy has declined from 7 years, 7.2 years in 2000 to 6.9 years in 2019, which means that longevity at birth and so on have increased and improved a lot. But at older ages, it is not improving. 2, there has been increased sex differentials in the average longevity. And for this, we illustrate the leading causes of death. First, among young adults, age 30-34, and the leading, that is deaths per 100,000 persons, the leading cause of death is TB among males, HIV among males. Road injury has moved up now, is the 3rd leading cause of death among this group. And then interpersonal violence. These things were not leading causes of death 20 years ago. So we need to rethink of them. 2, there's a mixture of both NCDs and communicable diseases among the top 10 leading causes of death. If you check for females, the maternal conditions, and I think this is why you have one presentation on maternal mortality. Maternal conditions are the leading causes of death, followed by HIV, which is still related to reproductive health, and then TB. TB, we know, is preventable, is treatable, but see how it has persisted among this group. Now, you can also see at the bottom, for both males and females, stroke has come in for both males and females, And then you look at self-harm, which means that there are certain things that are changing in the leading causes of death. Now, if you look at among the 60 to 64, these people whose life expectancy is not changing. On the left, look at the males, stroke is the leading cause of death, followed by cirrhosis of the liver and ischemic heart disease. These are the top 3 leading causes of death, but you see down there that TB has persisted and diabetes has come back, which was not there 20 years ago. And then you see the persistence of road injury as one of the leading causes of male mortality. If you look at females, the heart disease is leading, followed by neonatal conditions and violence, then stroke. And you still see that even after 59 years, maternal conditions have still persisted. These leading causes of death have important implications, and we need a lot to think about them. Now, I'll focus on my last, I'll not talk about because what kind of mitigating factors, but first, before we have mitigating factors, we need to have evidence. But there are these 8 things that we need to take into account. The widening sex differentials means that the gendered nature of cause of death and morbidity. High inequalities in health outcomes. There's no change in risk of death at older ages. There's a dramatic change in the burden of disease over the last decade, particularly the major causes of death and major causes of morbidity. But before we talk about mitigating factors, we have inadequate data from adult mortality and morbidity. And this inadequate information, we just recently completed a study in which we saw the high prevalence of multi-chronic illnesses among older persons in Nairobi. That the proportion of people who have 3 or more multi-chronic conditions is about 13% or 15%, particularly hypertension, arthritis, and diabetes, all combined together. So, what do we need to think about? We need.
Prof, we can't hear you.
Oh, have I lost?
No, you're there, Prof. We can hear you. I can hear you.
Okay, 2 things we need as yesterday, Kenyan Health Observatory. I do not have to go to WHO to look at the data and so on. We need regular and timely publication of burden of disease, not at the national level because health is devolved, but we need to have this at county and sub-county levels. This is when we can identify appropriate solutions. As at now, we do not know the sub-national differential, the geography of the burden of disease in the country by age and sex. And this is the beginning on how we can start mitigating adult mortality, adult morbidity. We have made improvements in maternal mortality, but we have not made improvements on the others. Now, if we have COVID added to this, people with 3 or more conditions, then you can see the kind of burden that we have. I don't know if there are people from the insurance industry, both from the public and private, but I'd like this question to be carried out even through up to the plenary. What life tables do we use to compute whatever we pay, the premiums for the insurance for health, and for which region? Because we know that there are wide regional differentials in cause of morbidity and cause of death. What do we use as the benchmark to compute the money that we are expected to pay for our insurance? 2, we need a lot more studies on how we protect some of these conditions, persist and they cost families a lot of money. How do we compute insurances for those who contribute for their insurance? The way we buy annuities, how do we arrive at the annuities that we buy? It is linked to the insurance. Thank you.
All right, Professor, thank you very much, Professor Alfred Kwanda. I think you have given us an overview of the current causes of adult mortality. And you have also given us a bit of on how we can have a discussion on areas of intervention. So you looked at the issues of the widening sexual differentials, the high inequalities in health outcomes, and the changes in the risk at older ages. So I think that was a really very insightful presentation from you. I know the panel, the participant really request we will give you an opportunity to ask questions later, but you can also put your question and answers just on the chat there. So some of our reporters are picking those questions. So let's proceed, dear panelists, to the next presentation, and that's coming from Dr. Duncan Kibongong. Dr. Duncan Kibongong is the Deputy Director of Safety Program at Education Education at the National Transport and Safety Authority. Dr. Duncan, are you there?
Yes, I'm there.
Welcome. You can introduce yourself, Dr. because I don't think I have done fair to you to in that.
All right.
You know.
First and foremost, thank you so much for having me in this particular meeting and this particular conference. My name probably you see up there on the screen. I'm not sure, Professor, they're able to see something on the screen. Just to confirm from my end.
Yeah, you can see it, Dr.
Yes, right. So my name is Dr. Duncan Kibongong. I'm working in the National Transport and Safety Authority. That is the NTSA, and majority of us know NTSA. I work in the Directorate of Road Safety as the Deputy Director in charge of the Road Safety Program. I'm actually the head of that particular department. So my training, by the way, I'm a medical doctor with a master's as well. In issues touching on public health and strategic management, and a number of courses and trainings touching on road safety. Worked before for WHO for about 5 years, then subsequently came back to government in NTSM. So that is myself, Professor Sheikh. I think I can begin the presentation, is that right?
Doctor, go ahead.
All right, right. So my presentation basically touches on this aspect to do road safety, and I'm gonna be very quick. Statistics worldwide show that about 1.35 million persons die because of this particular problem, and that is in excess of. And if you talk about injuries, the morbidities, we are talking about in excess of 20 million, actually going to the tune of over 20 to 50 million get injured, and a number of them get disabled. As we speak currently, it remains the top 10 cause of death, and we are talking about 3,500 persons dying every. You're talking about 3,500 persons dying every day in the global scale, and that is quite huge. You're talking about 3,500, and it is the common cause of death, actually the leading cause of death between that age group of 15 to 29. And if we do nothing, currently it remains about 9th, probably about 7th cause of death globally, and it's going to become the 5th cause of death by the year 2030 if we do nothing. So that basically shows a graph which we picked from WHO. In the year 2004, road traffic injury was the 9th cause of death. And the estimation is that it's going to be the 5th cause of death, killing more than diabetes, killing more than HIV, killing more than TB, killing more than HIV in the global scale. And the projection is it will be about 2.4 million deaths per year by the year 2030. So this is a worsening problem from global scale. And this is a data we got from World Bank. And here we are talking about in terms of the cause of morbidity. And this was around 2010. And you've seen that it has shifted from being the 9th cause of death to become the 8th cause of death. And as we speak by the Global Status Report of 2018, it has really gotten worse. And as a matter of fact, kills more than some of the other diseases. And if you talk in terms of the disability adjusted life years, it's one of the major causes of disability, so much so that, and I think most of us know that if you see someone who is having some form of injury, one or the other one, limping, for example, or in a wheelchair, what goes through your mind is likely, what type of road traffic accident was, crash was he involved in? So this is what it is. And the unfortunate part of it, or rather to put things bluntly, This problem does affect the low and middle income countries. According to the Global Status Report of 2013, road traffic injury hits the low and middle income countries, especially the African region, more than any other European or any other WHO region across the world. In African region, we are talking about the fatalities being about 27 per 100,000 population. And if you achieve that is quite high compared to, say, for example, Europe, the European region, which had probably about around that time when they did the study, 9.3 per 100,000 population. And yet African region have the least motorization level. And when you see this actually problem strikes across the spectrum, or rather all age groups, right from the young, and I think Professor mentioned this, all the way to the older age groups. And I'll show this by this particular presentation I'm showing, that in the male, according to that World Bank report, the ages, if you see the one I've rounded in red, it tells us that it affects virtually. Even the 4-year-old between 1 ages to 4 is the 9th cause of death. Here is the first cause of fatality, and the cause of mortality like 15 to 29. In the female, it's slightly different, and I think these are the trends you want to check. Between the ages between 1 and 4, it is the 10th cause of death. And it goes on, and if you see that it affects virtually every road, any other group. Between the ages of 34 to 44 for the male gender, it is the 2nd cause of death. Here is probably the 6th, 7th cause of death. And if you see, basically, the whole idea here is that if you rank road traffic injury, it cuts across all different age groups for that matter. But if you can see that it does affect the younger generation, and I think I'll be talking about that later. I did indicate that African region, there's a high number of fatalities in the African region compared to the rest of the world, and yet we have low number of vehicles in terms of what we call the motorization levels. So much so that in African region, I mentioned before, we talk about 27 per 100,000 population, and yet the vehicle population in Africa, we are talking about 46 vehicles per 1,000 persons. And in Europe, we are talking about 500 plus vehicles per 1,000, basically 1 vehicle per 2 persons. So the Europe basically, but you check this, it has high number of motorization levels. And yet in Europe, the number of fatalities that I showed before is about a third what is in African region, about 9 or 8. And the other thing we've also noted is that, largely speaking, the data we show or we share out or we coming from government, including some of us, are grossly underreported. And I think that is one of the themes of this particular conference, to understand the burden of the problem. To an extent whereby it's expected that in most of our regions, you talk about 4 times less than what we have. The numbers we have is, the real numbers would be 4 times more than that. So in Kenya, and this is the data for the last 2 years, and I'll be very quick on this, the number of fatalities in 2019, according to the data, and the data you get from the National Police is about 3586, compared to this last year, 2020, of 3975. That is a rise of 389. That is a whole 10% increase. Of significant increase, and I think this is one of the things which will come later, is we've noted the motorcyclists. We have different road users in that matter, either pedestrian, drivers, and all that. But motorcyclists, we are talking about an increase of about 500. 2020, we had 1575, and the year earlier was around 1073, denoting an increase of 500 plus in the year 2020, and that represents around 46%. That is quite a massive increase, and I'll be bringing this data to you. Right, and this is the statistics if we compare in terms of the road uses. If someone can mute, Mr. Lubanga, I think. Yes, thank you. So 2019, for example, we are talking about in terms of the distribution of the road users. Motorcyclists contributed 30%, pedestrians 39%, pedal cyclists are about 2%, and then it's distributed as we see it here. If you check, hello?
Okay, now I'm welcome away.
And we talk about in 2020, one of the things I wanted to show is the 40% of deaths last year were out of because of a motorcyclist. And a smaller percent, and if you see, we're talking about for example, the pedocycles is also quite high, around 30 something. And majority of these are the so-called vulnerable road users. If you add 30 plus 39 plus 2, those are what we call the vulnerable road users in the road network. I'll not talk much about this, but most of the fatalities, if you check across the time of the day, you'll notice that much of the fatalities do occur around between 4 p.m. to around 10 p.m. So much so that in the year 2020, we noted that in excess of 400 occurred around 8 p.m. in the evening. And if you check also the same data the previous year, the pattern is the same. I've done this data for the last about 5 years, and this pattern is repeated, and probably that's one of the things we discuss when the panelists are when you're going to have the discussion. The distribution across the week, the weekends starting from Friday into Saturday into Sunday, dramatically, we've noted that there's a massive increase of fatalities. In fact, the 3 days contribute more than 50%, about 52% of fatalities. The same trend has been the same case for the last about 5 years. And there are reasons to that, behavioral aspect of how our society is. Some of the things we probably discuss as we go along. This problem is said that it does affect all parts of the country. And we've done county by county, and this is the police statistics which we share, and we try to make sense out of it. Most of the fatalities do happen in the counties whereby there's increased paved network, the number of population is high, that is the number of people, and where the number of vehicles are high. And if you see this pattern, Nairobi, for example, the last 2 years, and actually all throughout has been leading, contributing to between, at times all the way to 20%, 15 to 20% of fatalities happen in Nairobi. And the numbers you've seen, last year we lost 481 and 433 the previous year. And as you said, it cuts across. Remember the issue of underreporting, because the best standard, or rather the best definition of a road fatality is up to 30 days post-crash. So if someone gets a crash today, up to 30 days, if you die within that 30 days, then that is defined as having died of a road traffic injury. This is the last 2 months of this year compared to the same period last year. Nairobi, Nakuru, and it goes all the way that way. Basically, the whole idea is that it's happening every day, it's happening all the time, and it's happening across the country. Age distribution, and I think this is something of importance, and it came yesterday in some of the discussions. If you check across the age bracket, you'll realize that majority, and what you're seeing up there on each of the bars are the fatalities of that particular age group. And the one in blue is 2019. The one in red, that is red for that matter from where I sit, is 2020. So if you see the ages between 24 all the way, say, for example, until 44, and if you can as well stretch it to 49, that is where most of the fatalities happen. We see a small spike around skill-going children, especially between 5 and 10, because of the behavioral aspect around the same. So this is the trend. Majority of the people who get killed are the young people, the most productive part of the society, and the people in the industry, and the people, the country depends a lot in terms of economic development and otherwise. In gender distribution, this we picked for the last 2 years, 2019, 2020. Male fatalities, for example, in this, what you're seeing there, the total fatalities were 3585, and a whopping about 3,000 were male and 600 were female. This was repeated last year, 2020, 3424 male, and you're talking here that 80+% of fatalities over the period. I have the data as well, and there are reasons to this, behavioral aspect and otherwise, something which I think we can discuss as we go along. Because of limited time, I'll not mention that, but gender distribution is what you've seen. Now, what you've done here is that we've done the motorcycles, which I mentioned before, which rose from as little as 5% contribution in terms of fatalities, all the way now doing 30+ to around 40+ last year. So what you're seeing here, pillion passenger, is the passenger who is in a motorcycle. And motorcyclist here refers to the rider. Actually, I should have put the word the rider. And what you're seeing there is the total for that particular year. So in the 2010, we had a total of 326. 200 were the riders, 126 were the passengers. that has dramatically risen to, I'm trying to move, has dramatically risen to 1,575 last year, being the riders total, and 1,136 being the riders, and 400, half of probably about that. If you see this is a general rise, a general increase in terms of this particular group when it comes to being the cause of death. And that is something of concern. That's a picture we picked, the border hospitals, which is across most of the country hospitals. But nonetheless, we have a corridor called Northern Corridor, which rises from Mombasa, an important artery in terms of transport, economic development, not just for Kenya, but for the region and East Africa and beyond. But this is an area which we've noted being an increasingly a top killer in terms of the contribution to fatalities. So much so that if you check some counties, like for example, Makueni County, that in the year 2020, we had 118 fatalities. 72%, which is about 85%, occurred in that particular corridor. And that is the corridor from Mombasa all the way to the Busia. And I think you know about that. So it's a top contributor. But nonetheless, when you talk about underreporting, we did add a discussion with the Department of Civil Registration under the Ministry of Interior. And we asked them to get us the fatalities from their hand whereby persons have been certified as dead because of road traffic injury. And we've noted from the year 2010 all the way to 2018, we are trying to work beyond there so that we probably share years in the future meetings. For those particular years, we've mentioned 2010, the number of fatalities reported by the police, even way before NTSA came into place, is about 27,000. But the number of fatalities out of the Civil Registration Department is almost double that, and here you're talking about 46,000. The difference being 67% difference. So, and if you check each of the groups, you'll see that the Department of Civil Registration has more people certified as dead because of a road traffic injury compared to this, largely because of that issue whereby, and we are currently working on this so that we improve on our data in terms of reporting morbidity and mortality. And that is why, and the thing, of course, with the civil registration, registration of death in this country, if I'm not wrong, and the team here are not be surprised that we have someone from civil registration, we are talking about registration of death in this country is around 40%. So even these numbers of 2018 of about, say, for example, 634 fatalities because of a road traffic injury reported by this particular department represented only 40%, meaning another 60% is out there. That tells you that the burden is probably almost double that. And indeed, WHO reports by their modeling for Kenya, the fatality stands around 13,000 to about 15,000. And that is the direction as NTSA, being the lead agency on matters road safety, is working towards. This is basically the trend, and I think I've explained that if you check the fatalities across from 2010, we are talking that the fatalities reported, and this is the so-called official, has been more or less a straight line. And yet, if you check the fatalities out of the registration of deaths out of the road traffic injury, there's a general increase. And even despite that, you are talking about a 40% registration of death, meaning many more are lost, something which I think is a conversation for this conference. And just a quick one as we finalize, we have, of course, different stakeholders. You've talked, for example, in Nairobi, the fatalities from the police at that particular time, 2018, was 441. But deaths in the civil registry is about out of is 1135, about double that. So if you see each of the counties, you realize that there is a double or almost at least a difference in terms of the number of fatalities between what is reported by police and what is reported by the Civil Registration Department, something which we need to work towards merging the same. And that is similar for 2017. The same pattern is repeated. The blue bar is always lower than the other one, and it's repeated all that. Indeed, we did a discussion with the DIHS2 with the Ministry of Health, and you see the civil registration, for example, in the year 2019, 61, and I think these are the fatalities we talked about, and the DIHS. So the whole idea here is this need to work, and that's one of the things we have already a project ongoing in terms of coming up with a proper data crash system in Kenya so that this data becomes more cleaner, we define the problem better, and we handle the problem better. And from an economic point of view, 5% of GDP is lost because of this particular problem. And 5% of GDP in the year 2019 represented about $96 billion. So 5% of GDP because of a road traffic accident as losses translates to about $1 billion, so about $478 billion, $4.7 billion. That translates to about 478. So in excess of 450 billion Kenya shilling every year is lost because of road traffic crash. We need to move this country to a low and middle income country by 2030, whereby the expectation is that there is an increase in GDP by more than 10%. And yet road traffic injury takes 5%. That is something of concern to ourselves. But we do have interventions, and I'll not waste much time on this. We are working on matters leadership and coordination so that we work around the overall overarching aspect of administration of road safety. We need to improve road safety funding, not just NTSM. I know all of us who are in government here have what we call road safety mainstreaming as part and parcel of their PC deliverable. That, of course, I mentioned that. But on the other aspect is working towards improving the road and road environment. Issues to do motor vehicle compliance standards and all that. Enforcement as a function of the National Police Service, driver training and testing, which is something which we've worked towards improving the same, amongst others, including education, children and education. We've currently working with KICD to improve on inculcating education in the school curriculum, including working with different stakeholders on post-crash care. Important thing here is that road safety interventions are multi-sectoral, and indeed, this is an emerging and a worsening problem. And data is quite important, but more importantly is what I've said, that interventions have to be data-driven and evidence-based. And indeed, I said it's a multi-sectoral sector, and it cuts across board because this is everyone's responsibility, and it's a shared responsibility. Thank you.
Good. Thank you, Dr. Duncan. That was really, thank you for educating us on the causes of road death and fatalities in our country. Really, those are very worrisome data. And we will come back to you just to give us what are the measures we are putting in place as a government to make sure that we overcome this challenge. So, dear delegates, our next presenter is Dr. James Gitonga, who is the Manager Maternal Newborn Program in the Division of Reproductive Health, and he's going just to give us an overview of what are the causes of maternal mortality and what are the policies that are in place. Dr. Gitonga, welcome, please.
Good morning once again.
Good morning, Dr. We can hear you. Go ahead, please. The floor is yours.
Yes, thank you. I'm waiting for the screen to be shared. As my name is Dr. Gitonga, as Dr. Sheikha said, I work in the Ministry of Health, the Family Health Department, where I'm the head of maternal health. So, as Professor said, maternal mortality is a special kind of adult mortality. You find that Kenya is among the countries in the world with the leading maternal mortality rates. You can see most of the countries are in Africa, where Kenya is one of them. And in Kenya itself, there exist disparities among the counties. Next slide, please. It is expected that about 6,000 women die from maternal causes or pregnancy-related causes, and every year. This is very high, and most of these, 90% of them, can be prevented. Next. So as you can see, about 14 counties contribute to over 75% of the maternal deaths in Kenya. These are the counties shown in yellow. And all those are ASO area counties. So a lot needs to be done to these counties so that we can reduce the country maternal mortality rate. We have made progress. We are 590 in the 90s, but the latest KDHS in 2014, we were 362, and they expected that when you do the next KDHS, we expect to have made some more progress. Next. So why are mothers and newborns dying? The main thing is that most of them, they don't have the opportunity to decide when to get pregnant. As we see in our countries, there exists a huge unmet needs for family planning. Even when they get pregnant or when they need care, there's limited access to skilled care, both in terms of access and quality. Then even the facilities, most of them they don't have the capacity to offer the comprehensive quality care for the mother, especially the emergency cases. So yeah, you can see the leading causes, the immediate leading causes is one, the number one is bleeding at birth, that is postpartum hemorrhage. Then the second leading cause of mothers dying during pregnancy or delivery is hypertensive disorders of pregnancy, that is high blood pressure. Yeah, the number three is infections or sepsis. The other one is where there's obstruction of labor, leading to sometimes ruptured uterus. And another cause is complications from abortions. Bleeding or septic abortions have also been a major cause of maternal deaths. So why mothers dying? I've seen that the mainly contributing factors are the three delays, which I will expand in the next slide. But there's also the issue of the weak health systems. I've seen most facilities don't have the adequate personnel and equipment. There are financial challenges both at the family and at the facility level. And even where there's care, as you have seen from the review of maternal deaths, most of the 90% of maternal deaths are this issue of quality of care that was given to this mother. So there's poor quality of care, even at the health care system. Next. So the three delays that contribute to mothers dying, there is one we call the first delay, that is delay in making the decision to seek care. This could be due to some education levels where mothers may not recognize danger signs, or there's places of decision making where you have to, mothers who have to wait for somebody else to make a decision so that they can be taken to the hospital. The second delay is where after you make a decision that you need to seek care, there's delay in accessing that care. It could be due to loans, insecurity. Then the third delay, which is one of the delay we can address, is the delay. Once you arrive at the place of care, that's the hospital or health facility, there has to be delays in attending these mothers. It could be to staff shortage, lack of equipment, or just unworking health systems. So these are the delays which need to be addressed so that they can prevent or they can eliminate the preventable maternal deaths. Next slide, please. Next slide. So what needs to be done? First, we have to address the quality of care. As I've said, 90% of maternal deaths that occur have issues of quality of care. So what the minister has done, with the emerging evidence, we have revised our national guidelines on quality of perinatal care. So we have new, which incorporating the new evidence, it is hope that this will help build the capacities of health providers in offering the quality of care. The other one is we should ensure that the life-saving commodities, the essential medicines are available at every point of service delivery. Last year, the ministry revised the essential drug list to include another commodity that is for prevention of bleeding after birth, that is it's levocabitocin. You know, what has been in use is oxytocin, but this is heat sensitive, and some areas in this country, the potency of this drug is affected by lack of code system. Therefore, introduction of this levocabitocin is expected to address this problem. The other one is ensuring there is safe plant and plant supplies and plant products. Most of the causes of about 8% is due to bleeding. And if we ensure that there's safe blood, then we can avert some of these deaths. Then the other thing is planning family planning services. And most of the mothers have issues in most of the pregnancies are intended. So if we can reduce the unmet needs for family planning by ensuring that quality family planning services are available to everybody, we may also contribute in the addressing causes of maternal death. And at the end of the death that occur to be audited, lessons must be learned from it so that we prevent similar deaths in future. So that was, we have, the government has developed what is called maternal and perinatal death surveillance and response guidelines that guide the healthcare providers in auditing all maternal deaths, coming with responses or actions that are meant to be implemented so that we prevent death from similar causes in future. Next slide. So what are some of the priority actions we recommend? We have seen from the reviews that most deaths occur during labor and delivery and the 24 hours after birth. So we must concentrate our care at that time during labor and 24 hours postpartum so that we can prevent death of mothers and newborns. Then we should also prioritize on high impact interventions that address the specific needs of various counties. These are things like making sure that every mother delivers under-skilled care. This has been done. We are now at almost 82% of skilled deliveries. This has been possible through the Linda Mama program that has made most of this accessible. Then the other thing is we should address quality of care. As I've said, most of the deaths we have audited issues of quality of care, that these mothers never got the optimum care quality. So we have issues we have targeted as improvement of skills to healthcare workers. The government has developed mentorship package on emergency obstetric care that is being rolled out in the country so that the healthcare providers have the current skills to attend to these mothers, especially emergency cases. Then we should ensure that this care is available to every girl, every woman, including the poorest and in the remotest area. This will be done through the universal health coverage. Then we should also involve the communities, the families, and the parents, because this cannot only be the role of the health sector or the government, it is a multi-sector approach. As I've said, where deaths occur, each death must be accounted, should have it audited through the MPTSR system so that there is accountability and measures are put in place to address these deaths. And then it calls for action by all. You need to have good leadership at the health facility, at the health sector, at the country. And we are lucky that in this country, we have good political will as far as maternal health is concerned. The Linda Mama program, which started as free maternity in 2013, has helped so many mothers to access the skilled deliveries and antenatal care and postnatal care because it covers for a whole year. We have the Beyond Zero campaign by actually the First Lady that is also addressing the maternal health. So all we need is more is to increase the financing especially by the county government so that enough personnel and equipment and commodities are availed for the maternal health. Next. Next slide. To address maternal mortality, also we need to go beyond medicine or beyond health. There are other issues that need to be addressed so that they can also complement the interventions from the health sector. We need to examine the social cultural values and attitudes and behaviors that compromise the girls and women from accessing health information that can save their lives. The discriminations against women should be done away with. We need to transform the attitudes and behavior that work against women so that all stakeholders within the community, especially the community opinion leaders and the religious leaders, can contribute and can support interventions that and investments in women's health. Next slide. So a lot of investment has been done on maternal and newborn health, and this investment needs to be sustained for the obvious reasons. One, it helps women and children realize their human rights. Health is a right now under our new constitution, and these women and children are expected to have the highest attainable standards of health as guaranteed by our constitution. It also stimulates economic productivity and growth. Where there are high maternal deaths and newborn deaths, it leads to slow economic growth, and there are losses, economic losses. It is estimated about 15 billion is lost worldwide in areas as a result of these deaths. It is cost effective to invest in maternal newborn health because essentially it prevents illness, it prevents disability in future, and this will save millions of dollars that would have been used for treatment if we did not put these preventive measures in place. And as they did, which have reduced poverty, because we have healthy women who are leading a productive life and productive life for their families and the communities. Next slide. So, as a ministry, as a health sector, our goal in the maternal health is that every pregnancy, end with a healthy baby, healthy mother, happy family, and happy communities. Thank you.
Good. Thank you, Dr. James Gitonga, the head of maternal and newborn health in the Department of Reproductive Health in the Ministry of Health. That was also a very insightful presentation. Ladies and gentlemen, dear delegates, now we are in the discussion session. We have seen those three presentations, very, very wonderful presentations. We started with Professor Gwanda giving us the overview of the causes of morbidity and mortality in Kenya, the 10 leading causes of mortality and the changing pattern in those mortality and morbidity in the country. He gave us the issues of, the physical inactivity, which are also leading to this problem, the urbanizations and, the current lifestyle that we're leading. We can, then we want specifically, again, what are the causes of, the adult mortality. Specifically, now we focus on the issues of the road traffic accidents. And here we have seen that Africa is less motorized, but again, has one of the highest mortality related to road fatality. And then we ended up with the last presentation that was done by Dr. James Gitonga, which looked at the issues of maternal mortality and the things that the government is doing. He gave us the 3 delays, and then they gave us the issues of quality services, and ended up saying that we want each and every pregnancy to end up with happy end, to have a happy ending. So, ladies and gentlemen, let's open the floor. You can just unmute yourself and ask a question, introduce yourself, say your name. We have 20 minutes to wrap up this session. So just you can, without raising your hand, you can just, you can raise your hand if I can see you from here, but you can also just unmute yourself and ask the question, but introduce yourself, who you are, and ask your question, and whom are you asking that question?
I'll go first.
Hello.
Hello.
Dr. Abdel, go ahead.
Hello.
Dr. Abdel, go ahead.
Yes, I just wanted, I appreciate this wonderful presentation. My question goes to Professor Wanda, where one of the causes of mortality in the 60-64 age bracket was maternal causes. I was wondering what these maternal causes are that are causing mortality and morbidity at the age of 60-64. That's number one. Number two, I wanted to know from the NTC presenter that whether there has been any study to link the road accident, deaths to corruption. Is there, because the interventions which I saw don't seem to address the question of corruption, because I think some of the accidents which happen because some of our enforcement agencies don't seem to be doing what is expected of them, and therefore defective vehicles and motorcycles and other things are on the roads. Those are my 2 questions.
Okay, thank you, Dr. Abel. I think we'll give opportunity to the panelists to respond to your 2 questions. One on the issues of the poor conditions of our roads, and also of vehicles, motorized vehicles. So, and the issues of the maternal mortality in that elderly, what do you call women. So I think we look at those two. We'll ask Dr. Gwanda and Professor Gwanda and Dr. Duncan to answer those two questions. Another question, Dr. Musa Rusey?
Yes, thank you so much for the good presentations from all the presenters. I also wanted to concur with the person who has just spoken concerning the road accidents and the corruption. I tend to think that we need to do more in that area, because I think the cost of more of these roads, we are losing so much in terms of money, in terms of people and the economy, because there is a lot of recklessness on the road. And the reason is just because it is actually linked to corruption. So if we can actually do something about corruption, then that might actually reduce. So if there is a study that will actually link corruption and whatever, and then we can be able to see clearly how this is related. Thank you.
All right, Dr. Musa Rusey, I think just following up with the question that was asked by Dr. Abel. So thank you very much, Dr. Kelly. Thank you very much. Any other?
Yes,
please go ahead.
Yes,
Dr. Professor, go ahead, Professor Duarte.
Yes, thank you very much. My question is regarding maternal mortality, and the speaker sort of highlighted the issues of maternal mortality in northern parts of Kenya, and it is true they probably have the highest maternal mortality in the world, but I think we glossed over the issue of maternal mortality in places which are better resourced, like the city of Nairobi and some of the regions in the western part of Kenya, which were all highlighted as having high maternal mortality. And it would be interesting to hear, what are we actually doing to reduce maternal mortality in this region? My second question is, where are we in terms of blood safety? A big cause of death in maternal mortality is lack of blood. Where are we in sorting out our blood transfusion services? Thank you.
Good. Thank you very much, Professor Duarte, Dr. Duarte, for that. Dear delegates, let me just now give the opportunity to our panelists, and I will start with Professor Gwanda. Professor, you have heard what the panelists are asking. They're asking the issues of that disparities. You mentioned, I think, some maternal mortality at that elderly age.
Maternal conditions.
Yes, please go ahead.
Yeah, the first thing is that we expect that everybody, that births don't occur beyond age 50. Two, maternal conditions encompass several other conditions. So it's not just maternal mortality, but those that are related to maternal conditions, ranging from cervical cancer and all the rest. Therefore, the whole data as compiled by the WHO is that all maternal conditions that are likely to cause morbidity and mortality, not necessarily that maternal death that occur within the 42 days of either pregnancy or within 42 days of giving birth. So maternal conditions encompass several other conditions, including cancers and so on. Now, if you check the civil registration data, you see women giving birth at age 60. What happens when it's at age 60? So check that report on the civil registration, you can get even trends. The birth registration and the age at which the woman gave birth. Yeah, I just wanted to mention, of course, this is from Dr. I know World Bank is supporting road safety study in Africa, and in which one of the lead agency, the lead person in the study is a Kenyan, Professor Winnie Mitula. The fact is that many of these questions are unanswered because we do not study critically what happens. We assume, or we have an opinion that this is what has happened. First, how many deaths are due to road infrastructure? Many roads are being done, but they are incomplete. No street, no lights, not marked, and so on. So there are several host of conditions that cause road deaths. Three, the so-called border motorcycles is causing havoc. And even recently, one of my colleagues was knocked badly because a motorcycle was riding in from wrong side. So management, and then behavior and attitude. These are things that have not been studied, and I think we need a clear study of road traffic accidents, but it's not just road accidents, because some occur on the lake and the rivers and so on. Blood safety, I agree with Professor Ruth Nduati. We did a study in Kilifi and Homa Bay, and we found that some of the conditions that led to maternal deaths were actually once they were in the facility. We need to take, with the launch of maternal surveillance and so on, we need to partition how many deaths occur due to delay 3, delay 1, delay 2, and so on. So those are my comments. Thank you.
Thank you, Professor. Thank you very much. I think you have clarified the issues of that maternal conditions that lead to death of women at that elderly age and others. And I think you clarified the issues of the issues of data and research. I think we can now know where we can get some for more information. Let me also give this opportunity to Dr. Duncan. Dr. Duncan, I think the question was issue of now the concern that we have in Kenya is that are we putting poor quality vehicles on our roads, poor roads, are we constructing poor roads, and also our behavior, both as citizens and also the guardian of this city, what we call our laws, are they also following the guidelines, and are we compromising with our systems? That's the same of the questions that were raised, and I think you can answer also that one. But also on that, right, that is also the issues. You showed, the disparity. I was wondering, when the average vehicles in Europe is 500 per, you said per, is it 100,000? And in Africa, it is just a 4700, yeah? And that disparity, and they have more fatalities in Africa. I think that is really, it is really worrisome. What's happening? Africans, is it because we are getting poor quality vehicles or road, or our roads are a problem? What Professor has mentioned about, we are putting roads, but they have no street lights, they have nothing. So come on, please, and explain to us on this, Professor Daktari.
All right, thank you so much. Thanks, and I'm going to take those questions, not in any particular format, but I'll start it this way, that matters touching on interventions of road safety, to begin with, are multisectoral. So, and that the fact that it's multisectoral does not mean it's just a government function alone, but spills over to the society and virtually everyone at large. Why I'm saying so is because in excess of 85%, probably even 90% in other jurisdictions, of what causes road traffic accidents are crashes are behavioral. So behavioral in terms of so many things. One, when you drive, whether you drink and drive, whether you're driving badly, whether you have license to drive, whether you've been trained to drive, among so many others. So that's why we're saying that it's behavioral in nature, and it cuts along a number of areas. Now, a question was asked here about whether there's been a research touching on touching on something to do with corruption and how it relates. Those are some of the things which I think such forums and many other fora and people and institutions who deal with research can are better placed to understand that. But if you see my presentation, one of the things we are working around on is the issue to do with improved enforcement. And when you talk about improved enforcement, it touches all those aspects, even including working towards trying to eliminate or reduce the issue with corruption. Just to say that corruption, of course, does affect every sector. Even in the health sector, if the medication, or rather the drugs distribution network is affected by corruption, then definitely it's going to affect it. So without saying that does, but the question is to what extent is something probably which needs to be documented. So the interventions you are working on, and remember the word multisectoral, is that it touches both on the behavior of the person, and that is what you're talking about, the safer road user. And here you are talking about the driver training, testing, and licensing. In Kenya, for the longest time, we've never had a standardized way of driving of a driving school. If you go to one driving school, what they teach you is different from another driving school. But with the advent of NTSA, we have now a standard curriculum of how these people are tested. The instructors, we are working also to have a standardized ways how instructorships are done. The testing, of course, initially it was a police function. Currently, we've taken it over in the last, I think the last was around December last year. And we're working towards improving and ensuring that the standardization of the testing and the licensing part of it. Issues to do public education and awareness, something we're working on around. Of course, issues, and I talked about the school, having it in school programs, among so many other areas which touch on the behavioral aspect. Engineering aspect is what we call the safer roads, so that we have safer roads and mobility. And that is something for a very long time, of course, been neglected, but working towards it, whereby we need to have roads which are safer and taking care of particularly the people we call them the vulnerable road users, amongst others. So those are some of the things you're talking about, alcohol issues and many others. So we do have a program, but remember what you kept on saying, we have a national action plan, which we're going to launch soon. We had a Global Road Safety Week a week ago. And this brings all the stakeholders, the researchers, there's always something for everyone to do. So, Professor, I think that is what I wish to say as relates to the questions asked towards my direction. But you can always engage as we move along. Thank you.
Thank you, Dr. Thank you very much, Dr. Duncan. I think the issues of road safety in Kenya, I think this is, you know, the currently you have shown in your data from 9 now, it's moving to 5. And I think this is a discussion that we need to continue even after this meeting. And we'll also be glad to join the conference and other things that you want to plan. Let me ask the last question, the question that were also asked Dr. Gitonga. Dr. Gitonga, Dr. Ndwati asked the issues of the disparity, the regional disparity. But again, as much as you can say maternal mortality in northern Kenyans are part of the Victoria Basins, and we know what are the causes and why they're leading. But then why do we have maternal mortality, high maternal mortality again in somewhere like Nairobi, where it's an urban setup? So I think she was asking that question, why that disparity exists still, and what are we doing about it? And then the last one she asked about what are we doing about the blood safety? And I think that is the major cause of death in our country is the lack of, is bleeding and hemorrhage and lack of blood that causes maternal mortality. So Dr. I think, and with other questions that were asked, yeah, go ahead.
Professor asked about the high maternal mortality in Nairobi is true. Nairobi has very high mortality. Most of the cases are referred to Nairobi from the counties. Secondly, although Nairobi is a city, is assumed to be things are good, there are some sections of the population of Nairobi which are at disadvantage in terms of access to quality of care, the slums settings. But since the inception of these Nairobi metropolitan services, we have seen some improvement in building of facilities in the maternity, facilities in various slum areas. We expect that this now will improve the situation in Nairobi, and at the same time, remove the pressure on the referral hospitals like Kenyatta, so that they can concentrate and give quality care to the referrals of maternal cases that actually need specialized treatment. So Nairobi, the population is also high, so the author has been there for facilities who are not adequate for the population, but I think the authorities, the government, both the county and the national government through MNS, and increasing those facilities. Also the quality as Dr. Koras pointed out, the assessment will also be an issue, but also the quality of care. So it's being addressed. There are many trainings, capacity building in terms of human resource, equipment and commodities that will go a long way. On the issue of blood supply has been an issue throughout this country. The situation deteriorated with the end of the funding that was being given to the regional blood centers in the various parts of this country. There are discussions with county governments where these centers are located to come together and they allocate resources to run this country so that that's the way of sustaining these plans, regional banks. So they can't stocks at the council of governance so that the county governments that are served by these regional banks can allocate funds to ensure that the services are running. The other thing is that during the COVID, what has been happening traditionally is that the main source of bland has been the educational institutions which closed with the COVID, but the National Bland Transfusion Services have now engaged other ways. They are mobilizing plans from other sources like bus stops and other regions where from other people without only focusing on the students. The other thing we are doing so that we reduce the need for transfusion is that we are encouraging the intervention put in place so that the ANC starts very early. We encourage every mother to start ANC at the first trimester so that those with low HPs can be corrected so that by the time they are going into delivery, the HB is okay. Because if the mothers go into delivery when they have low HPs, there's more loss of blood. Yes? Am I audible? Dr. Sheikh?
Yes, we can hear you. Thank you very much for that. Again, respond to that question that was asked by the professor, and that the government is doing a lot in terms of how to deal with the issues of maternal mortality and the issue of blood safety. I know we're doing a lot on that, and as a government, I think we have tremendously improved. I think we have made progress in terms of maternal health. I think with the Linda Mama program, with the Beyond Zero program, I think we have done a lot. And I think we need to put more efforts. I know Nairobi, with this investment right now the government is doing, I can assure you it will improve with these new facilities, their maternal mortality. But the issues of cost, we need to look at that one because some of these probably, some of the poor setups may not be accessing service because of funds, because of the cost. Christopher Curry, I know you are raising your hand. Is there very quickly, please, if you can ask your question?
Yeah, this is Musa. I'm using Christopher's Korea machine. So I'm Musa from this venue, and I'm supporting Nyandaro Nakuru County. So I know one of the interventions of reducing maternal death within our counties and even at the facility level is having the audits on the number of the cases of death within our facilities or within our counties. So I'm interested to get to know the data, the level of the extent of having the audits and the implementation of them.
So we lost Christopher, but what Dr. Agit, what they're asking is that the maternal audit and the data, whether that information. I know Dr. Gitonga, your team.
Thank you.
Yeah, thank you very much. Dr. Gitonga I know you can reach out to. Thank you. We're just, we are pressed up with time, and really we want to conclude this.
Dr. Sheikh, I would like to kindly ask that included in the report is the issue of human resource. Some of the maternal mortalities, the study done out of Pumwani was an issue of competence of the health workers, not enough competent individuals. So operations being done by individuals with little skills, like your interns without enough supervision. So doctors acting as assistants, theater assistants, not enough nurses as theater nurses. So the human resource component, even, as a significant contributor to this maternal mortality. And there's work published on that.
Thank you, Professor. I think that is really, again, another very useful information, that the causes of maternal mortality is also the skills and the capacity of the staff who are dealing who are handling the mothers. So I think that's an area that also we need to address as institutions and as a government. Dr. Gitonga, that information again, I think you can put in your. We can have more conference on these specific conferences, so we can organize that one. There were some issues that were raised here. I can read some of them from the charts here. Some are concerned that even during the COVID-19, when we had these curfews, even still death due to road traffic was, high. And then the issues of the pedestrians that, in the presentation that was done by Dr. Danka, you can see in the road traffic accident, you had more pedestrians dying than the passengers. And it's also worrisome because is it that we are not giving enough what you call space for pedestrians where to walk? Yeah. The issue of talk of sensitization, of road users, I think people are raising that. There was the issue of the human resource, which also Professor Duarte again you mentioned, which was again raised here by Dr. Dan. And then also Chris Kenyanjui was raising the issue of again the pedestrians. So I think some of the comments are here. We will take these comments during the report writing to be considered in our draft policy. So I think for me, I think it is 11:42. We were supposed to finish by 11:40. I just want to take this opportunity to thank the panelists, the presenters, yes.
Can I mention something?
Yes, Prof.
I think we are trying to forget. You saw the number of persons dying because of self-harm and so on. I think there's a critical area that we are not attending to. That is mental illness, depression, and so on. We don't know the prevalence of depression in the community at every age by sex and so on. There's a rising, there's a very high, the rise in the persons dying as a result of self-harm is alarming, and therefore we need to think of what do we do with mental illness, and it will cut across even other conditions. That's what I wanted to raise. The second one is access to healthcare. And one of the key areas that I think require restructuring and policy is health insurance. We are not addressing health insurance at all. So those are the things that I wanted us to raise and think about.
Thank you, Professor, again. Thank you again for those inputs again. Dr. I know the Professor and the team here and the panelists and the delegates here, I know we are not doing justice to this what you call topic, this thematic. It is about morbidity and mortality in adults. And I know this one we can discuss the whole week, the whole day. And that's really, it requires probably another sessions and a conference of its own so that we can discuss. But Professor, thank you very much on the issue of self-harm. I think it's also, we have seen the cause now, the number of deaths related, to issues through suicides and other related, what you call self-harms. And the issues of healthcare service access, I think is a debate that as a country we are engaging every day. We're talking about it and how we can improve on that. Ladies and gentlemen, I just want to thank our presenters, Professor Alfred Agwanda, who did that presentation of an overview of the causes and the leading causes of morbidity and mortality in adults in our country. And he gave us an overview of the 10 leading causes. And he mentioned the issues of, I think right now we mentioned the issue of self-harm, access to healthcare services, the issues of, lack of physical exercise, that's also leading causes, contributing to these high causes of morbidity and mortality. We looked at the issues of road traffic accident, and Dr. Duncan, I think, presented very well, as a country. And I think NTSA, which institution that was just recently formed, I think, for me, I just want to congratulate them for the good work we have done. I think we can see with those statistics, initially, those what we used to lack. And I think the statistics are shared in the global statistics comparing to Africa, again, back to Kenya. I think, again, this was an amazing presentation. And I think the issues as a country, on the issues of our behavior and, our culture in terms of road use, I think it's very important that they mention. And then the issue, then Dr. Gitonga, he talked about the 3 delays, the delay to make the decision, the delay to go to the health facility, and the delay to get the services. And that's really a very major concern in terms of maternal mortality and other reproductive health services. So I think, ladies and gentlemen, I was your chair, Dr. Muhammad Abdelkadir. I will do this on behalf of Dr. Mercy Mwangangi, who could not join us because she had another meeting ongoing. So I want to take this opportunity really to thank the panelists for this wonderful preparation. I want to also thank the delegates who are in this room, breakout session room, for really also that wonderful contribution. With that, I want to say thank you very much and go back to the main session. Back to you, Peter Nyakwara, and the team there. I know we still have 2 minutes, or I can say we have, is it?
Thanks, DG. Thanks, panelists. Thanks, dear delegates, for this session, which has also been very stimulating. There are a lot of new issues which have come out of this issue of maternal mortality. It has been very stimulating. You have about 1 minute so that the rest of the session can be concluded, I wish to request that the co-hosts ensure that the complete recording of these sessions. Please, co-hosts, confirm that you have done the recording completely. And also, the other request we are making is that the chairs of the various sessions, with the support of the rapporteurs, kindly flag out 4 or 5 issues takeaways so that when we go to the plenary, we can be able to share with the rest of the delegates. Those are the issues. We will break for
The other groups are not about to join.
yes. We'll break for about 10 minutes. Then we will resume the last session for current sessions, which will come. We are waiting for the other team to come on board. Then we have all of us will be on the same page how we proceed. The room was there. We are warming up the last sessions. Country delegates continue also sharing your networks, in our social media and your networks. Thank you. We give 1 minute to our sessions to complete. Welcome back to plenary. Dear delegates, we are now having a break of 10 minutes so that at noon we'll resume for the next concurrent sessions, which are going to be 4 of the sessions. We have under theme 5, population, human settlement, and environment. We will discuss theme 5.3 on hazards and risk response.
It's okay.
This is the session that will be chaired by Dr. Duncan Cheng, the Director National Disaster Management Unit. Then we have also another sub-team on data innovation and research, focusing now on innovation and the data availability. And this is a session the Director of Modern Evaluation Directorate, that team will chair. Then the 4th session will be on the theme education and training, where we focus on role of education and training on harnessing the demographic movement, and Mr. Frederick Canon Chris Kinajui will chair that session. Then there's a resource mobilization, the Met area, where we have got a sub-team on towards sustainability, where we focus on public and private sector resource mobilization for the population program. And this the session, which is going to be chaired by Engineer Honorable Mark Nyamita, the Vice Chair of the Parliamentary Network on Population Development, then before really. And in this session, the Chair of the Board will introduce Honorable Nyamita. So kindly let us break for 10 minutes. At noon, we resume in our breakaway sessions. The host confirm that you have completed the recording of proceedings of each session. We had also requested that when we come back for a plenary wrap-up, the various chairs of the session with the support of the rapporteurs, frag out 4 or 5 issues step away from the proceedings of those concurrent sessions. Thank you.
Hello.
Our next topic is a very, very important topic. It's the topic of resource mobilization. Throughout this conference, we have discussed many things. And in order to get to implement those things that we'll come up with, we can only do so when we have enough resources. You are aware, or you may not be aware, that we have 10 regional offices, but we are supposed to have 47 to be in all counties. But we can't do so without enough or adequate resources. We have a staff establishment of about 200, but we only have about half that because we don't have resources to get the other half. And we are part of we fall under the National Treasury. We are Kenyans, and we know that the government has a limited purse. So it's so important that we also mobilize the resources. And so this is why I say this topic is very important. And to lead us in this session, which has the subtopic of towards sustainability, public and private sector resource mobilization for the population program, is my friend, a very, very capable chair, Honorable Engineer Mark O. Nyamita. Honorable Nyamita is the current MP for Orere constituency and Vice Chair of the Parliamentary Network on Population and Development. He is also a member of the Budget and Appropriation Committee, as well as ICT Committee of the National Assembly. Honorable Nyamita holds an MBA from Strathmore Business School and a BSc in Civil and Structural Engineering from UCAT. He has also attended a general management program from Indian Institute of Management and a young talents management course at the University of Witwatersrand, South Africa. Nyamita, sectors. And then he's an entrepreneur and an associate member of the Kenya National Chamber of Commerce. Like me, Nyamita is married with 4 sons. Welcome, my brother, Honorable Nyamita, to take us through this important session of resource mobilization. Karibu.
I don't know whether you can hear me.
Yes, we can.
Yeah, thank you. Thank you very much. My name is Mark Nyamita, Member of Parliament for Orere. I think the introduction, my colleague there, Honorable David, has done justice to it. You might have noted that we are sort of late into this session. So in this session, we're going to be talking about resource mobilization. And we have a couple of people who are going to be our panelists for today. I will begin with probably giving my short speech. Thereafter, then my panelists will be able to go through. So I think how we're going to do it is that I'm going to go through, we go quickly with a quick round of introduction of the people who are going to be in our panel. And we do hope that within less than 90 minutes, we should be able to be through with this. So the first one on the panel is Evelyn Samba. Evelyn Samba is the current country director for GSW. She has a master's and MA in community development, BA social work from the University of Nairobi. She has received various training in development and strategic leadership. Evelyn Samba is a development expert with over 20 years experience, drawn from working with civil society and government. She has hands-on experience in human rights-based approaches, program design and management, community organizing, and policy advocacy. She's a trainer in human rights, gender, and participatory methodologies, and has vast experience in sexual and reproductive health, women's rights, and governance work. If Evelyn is already on, maybe you could just show your face and say Jambo.
Good afternoon, everyone. This is Evelyn Samba. I'm looking forward to participating in this panel. Thank you very much.
Thank you, Evelyn. Our next panelist after Evelyn will be Mercy Waidanji, who is a member of the KEPSA Gender and Youth Development Sector Board. Mercy is a mentor of women and youth in business, both institutional, startups, and growth strategies. She's participated in various public and private sector partnership forums, peace, environment, conservation initiatives, and advocacy, particularly on matters that speak out for women and youth inclusion into the decision-making table, including forums which deal with policy implementation. Mercy is currently serving in boards of Kenya Association of Women Business Owners, KEPSA Youth and Gender Sector Board, Devolution and Planning Sector Board, and the Amani Foundation. She's been in the insurance industry for the last 16 years and has experience in management of staff teams across diverse spectrum, professionals, specialties in enterprise development, business advisory, sales, and other support functions. If Mercy is within, Mercy also, we could just get to see you and you say Jambo very quickly. Mercy. Okay, I'm sure she will join us at some point, yeah? And then I have the...
She's muted.
Oh, she's muted. Can our admin please...
Sorry about that.
Okay.
Sorry about that. I hope you can hear me now.
Okay.
Thank you for that very good introduction, Miwa. And I'm very happy to be participating in the 4th National Leaders Conference on Population and Development. Thank you very much.
Very well. Thank you, Mercy. And then finally is Dr. Ezigaldi Helinov. I hope I pronounced that right. Dr. Helinov is a UNFPA Deputy Representative in Kenya and is from Turkmenistan. Wow. He's working with the UNFPA from 1997. Before joining to Kenya team, he was a Deputy Representative in Yemen, UNFPA Regional Advisor, Humanitarian Focal Point at Eastern Europe and Central Asia Regional Office, and Emergency Coordinator in South Sudan, CEO responsible for UNFPA Humanitarian Program in Darfur. He holds a Doctor of Medicine, Medical Sciences, Scientific Degree in Pediatrics from the Institute of Pediatrics of Russian Academy of Medical Sciences in Moscow. Dr. Helinov, if you're on panel, maybe you could just say hello.
Thanks a lot, Chair. Thanks a lot, Chair. Dear colleagues, dear delegates, it's great pleasure for me to be with you today and discuss population and development program issues. So I am looking forward to having very fruitful discussion. Over to you, Chair.
Thank you very much. I think that does it for panelists. We should have had someone from the Ministry of Finance, the Treasury, but looking at the panel, I think we will still do justice to this. Now, without further ado, I'll just go to my opening remarks. And I think I was asked to talk to this issue of resource mobilization, public and private sector resource mobilization for the population program. So I'll go through this hopefully in the next 5 minutes. Then now we'll have the panelists, and then we'll have a Q&A. And I hope that we are going to be able to manage this within our time. So to fully appreciate the backdrop against which we ought to consider options as a country in view of Vision 2030 in the fast globalizing, knowledge-driven global economy, it's crucial that we unpack patterns of demographic growth from the world perspective. Then we will reduce it not only to Africa, and I think to Kenya. So today the world population stands at about 7.9 billion. Yet back in 8,000 before Christ, at the dawn of agriculture, the entire world population was just about 5 billion people. By the first AD, the population had soared about 200 million. Others would peg it at about 300. Yet still others would say it's about 600 million. The staggering projections show just how imprecise past population projections could have been. The foregoing notwithstanding, since the first industrial revolution, the global population trends changed dramatically. By 1930, the world had about 2 billion people. And by 1960, global population stood at about 3 billion. Within another 15 years later, precisely around 1974, the world population climbed to about 4 billion. In another 13 years, around 1987, we'd hit about 5 billion. Within the 20th century alone, we can say the world population moved from 1.65 billion to a whopping 6 billion people. In the year 2100, we expected, it's projected that the population is going to be about 10 billion people in the world. In a nutshell, I just want to demonstrate how that as the human race advances in science, technology, and medical discoveries in particular, so does the population tend to grow faster. At the same time, the very same advancements help in reducing human mortality. So as technology grows, as other changes happen, population is growing, but we are also losing more people. If we look at the African perspective, about 6,000 years ago, the African population was concentrated in the northern hemisphere, where farming had been developed, constant invasions by the increasingly the belligerent Europe between about 11th and the 16th century led to a constant decline of people in the northern parts of Africa. Add this to the infamous Black Plague, the emptying of the north eliminated further, then there was a concomitant population growth south of the Sahara during the Iron Tools period that also marked the beginning of farming in that very region. The most memorable setbacks with this regard to population in Africa are attributed to slave trade that stole from the continent well an estimated 100 million people. In East African areas, wars with colonial masters as well as other wars contributed further to the decimation of the region's population over time. Be that as it may, it is interesting to note that in Africa about 1,000 years ago, the population in Africa stood at about 33,000 people. 1,000 years later, at the turn of the millennium, the continent's population was at about 811 million. Today, an estimated population of about 1.3 billion people. And it is estimated by about 2030, we should be about 4.3 billion people. If now we bring it to the Kenyan perspective, the data that we have from 1959 and the census that we've had over every other 10 years shows us that from 1959 we had about 7.8 million people. 2009 was 41 million people. And the recent one shows that we are about 47.5 million people, representing about 12.2 million households. That's an average household of about 3.9, say 4 people. So the key imperatives for public and private sector resource mobilization for Kenyan population program. Having taken notes of the trends that define the demographic progression globally, within Africa, now in Kenya, we are interested let us now turn into the objectives of what we want to talk about today. To share resource mobilization trends, opportunities, and experiences in a constrained resource setting. That would be our first one. And the second one would be to share recommendations on resource mobilizations to support population and development programs. If we are able to, hopefully at the end of this, have a way forward on these two, then I think we would be heading in the right direction. So before addressing myself to these two objectives, as we wait to hear from the experts, financing agents and the private sector players, what options for resource mobilization we have, allow me to provoke you with a few queries that could steer the course of our thinking towards fresh, thus far little explored horizons. One, we are confining ourselves to Vision 2030, whose primary objective is to help transform Kenya into a newly industrializing middle-income country by providing a high-quality life to all citizens by 2030. The keywords here are industrializing, middle income, and all citizens. Ambitious as this may seem, Vision 2030 is not far-fetched either. I believe so because in the last 15 years or so, we have witnessed momentous and unprecedented modernization of what I would call the hardware side of our economy, the infrastructure, name it. However, when we speak to matters population, human capital, and social transformation, in the context of policy shift, we should ask ourselves, how much have we invested in transforming our software? To that end, some questions that beg answers include, but are not limited to the following. One, are population programs synonymous with birth control initiatives? Do we have enough resources in Kenya to support twice the number of people we have in the country today? If we double our population, will our resources support this? Can we talk about population programs while delinking them from our plans for economic productivity and projections thereof? How much of our Vision 2030 ideals, both that relate to the hardware and software, have we achieved thus far? And what resources do we need to complete this journey? So we probably need to take stock what we have done and what essentially are we seeking to, even to define the resources that we are talking about. With the global workplace changing and the apparatus for industrial production changing ever so fast, are we adjusting to the emerging realities in order to remain aligned, or are we lagging behind? Ladies and gentlemen, you know we're in the fourth industrial revolution, whereby everything is no longer predictable. Are we well focused to address the huge youth demographic that we already have? The world, I am afraid, is changing extremely fast. What may appear swanky and may very progressive today will fade in a flash soon. That is what technology has handed us. We have had little choice. We have little choice but to live with it. This reminds me of the word of Aikwe Ama from his memorable fiction, "The beautiful ones are yet to be born." When he said, and I quote, "The present is where we get lost if we forget our past and have no vision for the future." I want to repeat this. The present is where we get lost if we forget our past and have no vision for the future. Speaking to what I spoke to earlier, that we have to take stock, look at where we are, then we have a vision of exactly where we go. If we get so busy with the present as rendered fleeting by fast-changing technological advancement, we may consign ourselves to addressing phantoms and all manner of make-believes. We should therefore master the boldness to relate resource mobilization for any population program in the context of what the future holds. Number two, and the public and the private sectors joined at the hip when it comes to crucial matters that address population growth, as its implication to national social economic well-being and other related matters, including national security. A coherent strategy that ensures both public and private sectors work in total consonance to address population challenges is nigh. One of its core functions should address just not resource mobilization, but also deployment of such resources based on futuristic strengths that are easily discernible from the unfolding worlds of the fourth industrial revolution. So the two objectives, resource mobilization trends, opportunities and experiences in a constrained resource setting. Here we have several tried and tested options to borrow notes from, create models around, and some of the options include forging long-term relationships with donors and benefactors the aim being to create sustainability away from one-touch transactional approaches. Interlinking partnerships with resource mobilization in order to maximize the surrender value of shared resources, including human capital, knowledge accumulated over time, and the potential trust that participating parties are likely to build over time. Thinking about non-monetary resources as an integral part of resource mobilization, particularly where technical capacity and support may be quantified as a resource. Building a long view with significant partners that in turn promises predictable funding based on shared values and objectives. Organizing funds through annual events set around conferences, letters of request, all premised on the achievement of certain measurable goals. Switching to budgeting in accordance with needs assessment as opposed to expected resources. Better for us to cut our coats according to our sizes. In other words, identifying the most critical goals and seeking funds for them. This method has, in some instances, ended up increasing resources for some organizations. Our second objective, therefore, is recommendation on resource mobilization to support population and development. In the wake of a whole basket of new ideas and technologies driving the world today, we are called upon to, one, restructure funding ideologies to reflect new realities driven by the knowledge era and unprecedented technological breakthroughs, align resourcing to global thematic developments such as sustainable development goals. We make our country goals a priority as opposed to addressing the parochial objectives of a single entity whose work involves others, similar thinking elsewhere within the same jurisdiction. So we become realistic to our environment. Communicate results in a visible manner that encourages partners and donors to come and stay on board. Tightening the cooperation between the public and private sectors through negotiated joint programs informed by shared objectives, scheduled for specific timelines. Engaging philanthropic foundations and high net worth individuals and benefactors. And finally, approaching individual givers and finding appropriate ways of recognizing their contributions. As I conclude, as we debate how to conduct resource mobilization for population programs in Kenya, it is urgent that we also take full cognizance of the need to integrate existing knowledge of how population as a phenomenon affects human development and how different an era we occupy just now with regard to the vast technological transformation that will continue to redefine the world in the days to come. Should we keep our fingers on the pulse? We should keep our fingers on the pulse, even as we seek to tweak the policy to serve our dreams and aspirations, and as we scale deeper into the 21st century. Ladies and gentlemen, I thank you. So I think in summary, just to give the global population trends, of course, globally, in Africa and in Kenya, and try to seek what are the ways that then we can be able to address the objectives that we are seeking in the fourth industrial revolution, because things are no longer predictable as it may. With those very many remarks, I want to invite our first panelist, who is Evelyn Samba, to take us through a short presentation. And then the other two, then we'll open up this now for everyone to give in. Thank you very much.
Thank you, Chair, and thank you as well for setting the tone for this conversation. I want to call it a conversation because flowing from what you have said, you have delved into very, very important points that would inform this kind of discussion. You have touched on many of the points that I would have gone into. And I would just like to start by saying that all the way from yesterday and today, we have heard from the various sessions some facts. For instance, the fact that population will continue to grow, and you have reaffirmed that, not just for Kenya, but globally. and that as the population grows, it presents not just opportunities, but challenges as well. But important, you have also raised the important point, which leads us into this conversation, that we cannot afford to talk about population development without tackling the issue of investments into that conversation and into that agenda. So we are here then talking about what do we need to invest? How do we mobilize our resources to finance the population agenda? This would be very central and critical to the full implementation of our priorities, development priorities, but also realization of human rights, especially when you look at some of these issues as constitutional guarantees, and of course, being faithful to the commitments that the country has made in many of the treaties and conventions that we have signed. What has also come through from yesterday and today is that many actors are involved in supporting development and population agenda. So efforts from various quarters, both from government, from the private sector, and from the citizens as well. We can term all those as resource mobilizing. But the question is, how well are we performing? And the issue that I would like us to keep in mind as we discuss this is to note that largely Kenya's population programs have been funded externally over the years. In fact, it is also a fact that 73% of the family planning work in Kenya, in fact, let me rephrase that. It is a fact that family planning work in the country is funded largely by external sources to the tune of 73% of whatever resources that are required, leaving only 27% to other sources. What this means is that we are significantly reliant on funders outside of ourselves to resource our development or our population work. That is a big challenge, because as we now delve into the changing funding environment, we will see how precarious that can be. For instance, it is also recorded that the HIV programs are funded largely by donors and significantly by a handful of donors, 2 to 3. That also is another challenge, that when the ground shifts with those few donors, we are left exposed. We also can say that certain things have changed in our environment that then must be addressed as we talk about funding for the population work, for our development agenda. And we can take comfort in the fact that the government has already taken cue by formulating a formula that will allow us to progressively increase our domestic investments, especially for family planning by 2023. And this is also informed by what is changing out there, because the fact is—
There's a polite request to personalize it. If we could see you, if you're in a good environment, that is. Sorry.
Right, okay. Yes, so one of the issues is that increasingly, since 2013, the government has been required to step up investments in family planning and reproductive health programs because of our reclassification as a lower middle income country. And that means many of the funders who had looked at us as needing our support are actually calling on us to step up and fill that gap. So as they are reducing the investments to us, it is imperative that we see ourselves stepping into that space and investing our monies. So that is one of the things that are changing in our context, in the funding context, that I would like us to talk about when we talk about funding and resource mobilization for development and population work. The other change in this environment is that increasingly also we are seeing a greater demand for accountability. All right. So over the last couple of years, we have seen that many funders And it's not just funders, all of us, as sensitized as we are as Kenyans, we are continually asking questions about investments or resources that are being put into certain spheres, development work, program work, and whatever other sphere that you may want to look at. And that therefore this then means, unless we are accountable for the resources that we have, then our fundraising will be struggling. But following steadily from the conversation on accountability demands is also the issue that there is also increasing competition out there for resources. This significantly affects the fundraising environment in which we are going to be operating. So this is competition within and among the sectors. So for instance, you'd find even within the population work, there would be competition between various themes, but even across sectors, there would be a competition between population as a sector and something else. Might it be agriculture, food security, might it be education? So, and we are looking to the same funding sources to meet all these demands. I think to mention the issue of emerging needs and changing needs is to then take us directly into even what we are experiencing right now. With the onset of COVID-19, I think it is apparent that there would be new needs that will require attention. So these changes in needs especially has a significant bearing on the funding that we can talk about when we talk about our resource mobilization. Donor priorities are also changing in tandem. So all these would point us to the changing context in which our resource mobilization would be anchored on. And therefore, with all that, the question that we may want to entertain in this conversation is how then do we raise the resources? How do we, for instance, mobilize enough resources? And I'm happy that, Chair, as you spoke, you mentioned it's not just the money, it's also human capital, it's technical expertise, it's non-financial support that we may look for towards to be deployed towards development work, towards our population work. And therefore, one of the key things that we may want to talk about in this conversation when we talk about fundraising or resource mobilization for this assignment is to say that we must get to a point where our government invests domestic resources for population work. It is critical, it is urgent. Why do I say so? If over 70% of our population work is funded externally, and we have also been told, because now we are a lower middle income country, that donors are asking us to step up, then it is urgent that we then have that conversation as a country and begin to prioritize population matters and investing in that regard. But how do we invest our domestic resources? This should be at national and at county as well. And we have good examples to cite where we have seen a number of counties stepping up to increase the resources they're allocating towards topics such as health, or specifically reproductive health, if you like. That investment should continually grow because, as you mentioned at the beginning, it needs to be matching or even outrunning the growth in population if we're to meet the demands. But it's not just enough to talk about domestic investments, because we also know from experience, many a times we allocate and we then don't make it available for many reasons. So we are also saying part of the fundraising for population work must not just end at allocations that are increased from domestic sources, but that they must be ring-fenced. So that yes, we have resources allocated for that work, but that it is also secured in our documents as budget lines, so that then it becomes imperative that it's not moved. That's the first point I would like to talk about. The other point that we must then look at when we're talking about increasing our resource mobilization or investing more resources towards population work is to also talk about the issue of accountability, and you alluded to this. Yes, there is greater demand for accountability across board. How do we as a sector and as a country demonstrate that the resources that were given to us were used in this manner with these results. It is important because when we are that transparent, then it goes that further in strengthening our successes in resource mobilization. It also must include tracking the resources that have been availed and used to actually generate, if you like, evidence to show what actually was financed, how were they deployed, and with what results. Did we get the money? Yes. How did we use it? For what? And with what results? Part of that conversation then should also lead us to resolving systemic challenges around our resource deployment. We know that we have inefficiencies along the chain, and a lot of that, if they are plugged, then that becomes funds or resources that will be available for our population work. For instance, in our work in the counties, we know, for instance, when you talk about non-financial resources, let's say commodities, while on one end of a county, you would have serious shortages of commodities, on the other end of the same county, you would have another, let's say, facility or structure or system struggling with absorption. So dealing with inefficiencies, with pilferage and wastage would then also speak to coordination. Are we speaking to each other or at each other when we talk about resource mobilization? The other point that I would like us to then entertain is about profiling the agenda for population. Let us make this central to every discussion that we have around our development. And it has been said since yesterday that when you invest in family planning, for instance, when you resolve challenges around access to reproductive health information and services, you actually make savings towards development. So let's profile that conversation that way so that then people can begin to see, unlike others who want to see things that are physical, then they may believe that it was a good investment. Let us then make that conversation so central in everything that we discuss. That
3 more minutes, 3 more minutes, Evelyn.
Yes, I'm coming to
3 more minutes, Evelyn.
Right, thanks. Okay. Multi-sectoral approaches are key, and you mentioned this at the beginning, but also investing in community philanthropy would be another issue that we may want to look at, because we are saying if we did that, then we would then get to a point where we are clearly tapping into resources that are not necessarily monetary within our communities, looking at the network and the institutions that we have at our disposal, deploying them out there to do what we would have done with our monies, and therefore being able to deploy our resources differently. They come in with expertise and knowledge that can be beneficial to furthering the development agenda around population concerns. I thank you.
Thank you very much, Evelyn, for the great insights. I think you've overemphasized on a couple of issues. For me, one that stands out, which is in probably in my area of work, is that when we do allocate resources, let's avail them. So let's allocate and ring fence. Demanding for accountability, for sure, not only for locally raised, but also even money from the private sector, including our. The risk that also we run by over-reliance on probably very few donors. In case they change, then we are sunk. I think we'll move on to the next presenter, who is now from the KEPSA, Kenya Private Sector Alliance. And Mercy, as you come in, I saw someone raising a very critical question, that how do we get our true private sector? The specific question actually there is on our chat. We're not seeing equity, big private sectors in Kenya here. So Faricom, how do we get the private sector to change or to partner with us as we pursue Vision 2030, even as we do this? Thank you. Karibu sana, Mercy.
Thank you very much, Chair. And thank you, Evelyn, for that presentation. So I am going to talk about the role of the private sector in supporting population and development programs. And I will also share the lessons learned from KEPSA. Yeah, it's important that I tell you a bit about KEPSA, just a brief introduction. KEPSA is an apex body of the private sector in Kenya. It brings together an entire business community from all sectors of the economy under one umbrella to enable them to speak with one voice when engaging with government, development partners, and other stakeholders on cross-cutting policy issues that affect the private sector and national development. We have over 500,000 corporate members, and they are drawn from all over. We have over 80 local and foreign business associations. We have the Chambers of Commerce, including the International Chambers of Commerce Kenya chapter. We have professional bodies like LSK and ISPAC, corporates and multinational companies and medium corporates, and we even have SMEs and startups. KEPSA also supports business on training, networking, financial linkages, mentorships, coaching, access to markets, value chains, and access to investment opportunities with many partners around the world. So we have an engagement structure. We engage with the government in a very structured way through sector boards that identify policy issues at sector level and harmonize proposals before engaging with line ministries, state departments, and agencies. We have strong associations like the Kenya Association of Manufacturers, the KHF, the KTF. They take lead on sector-specific issues, while KEPSA pursues the cross-cutting policy issues. Why is population development matters very important to the private sector? So we find that the Kenyan economy is largely driven by the private sector, which contributes over 70% of the GDP, the GDP and jobs. It's a key stakeholder in the planning and implementation of population development. To private sector, the population provides ready market for goods and services, as well as the human capital that is required to run businesses, innovation, and entrepreneurship. For Kenyans to achieve its vision of a rapidly industrializing middle-income economy by 2030, the largely youthful population must be well-equipped and empowered to drive the transformation. Among the key concerns are, as Mheshimiwa alluded, the rapid population growth at 2% per annum compared to the job creation. This leads to high youth unemployment rate. We also have the high dependency ratio, which really adds an extra burden on the working population, and it affects the savings and investment of the working population. We also find that there is congestion in major cities. A question was asked earlier, if the population was to double, what would happen? So we find already congestion is happening, and this fuels growth into informal settlement, and it strains available infrastructure like housing, transport. We find so many jams, water, waste management system, energy, healthcare, education, and so on and so forth. We also find unsustainable utilization of available resources, and this leads to environmental degradation, pollution, and increasing climate change vulnerabilities, among other challenges. Let's go on. Yeah, so KEPSA has activities and programs that support population development. Among them is championing sustainable development. As the private body, KEPSA is a member of the SDGs Interagency Technical Committee at the National Treasury and Planning, and coordinates the implementation as well as reporting of private sector contribution to the SDGs through the National Review reports. When it comes to agency, KEPSA supports government development agenda, including the Big Four Vision 2030, the medium term, and the budget making by providing championing for sufficient resourcing of key sectors, and improvement of business environment to grow local enterprises and attract investments. KEPSA also health programs, the Kenya Healthcare Federation, that is KHF, the Health Sector Board of KEPSA providing care, including family planning, support in managing COVID-19 pandemic, as well as Wheels of Life. And about the Wheels of Life, I'd love to recognize the think tank of Wheels of Life, Dr. Jemima, who was recently awarded the WHO Director General Award in recognition of her effort. And the Wheels of Life has now been institutionalized, and it's been institutionalized and now works under a team of doctors, KHF, and continues to offer very critical services during this unfamiliar time of COVID-19. And what it does, it's an innovative program that helps expectant mothers to access hospitals during curfew hours, and not just expectant mothers, but others who are ailing. I don't know why emergencies happen at night, and especially now that there is curfew, but they are all attended to thanks to Wheels for Life. Continue the presentation. Irene.
3 minutes.
Yeah. So we also have better business practices for children, aimed at where we have made sure and encouraged organizations to make sure that they have lactation centers for breastfeeding workers, extended maternity leaves. We also have sustainable inclusive business, or what we call SIBK, supported by the Embassy of Netherlands to promote adoption of an integrated approach among businesses that that find a balance between people, the environment, that's the planet, and the profits. And we also have the African Venture Philanthropy Alliance that seeks to accelerate social impact investment in Kenya. Let's go on, please. Whoever is doing my PowerPoint, go to the 7th slide. So to continue with the activities, we also have gender focused activities, and we champion supplier diversity and affirmative action. We have ongoing of the private sector gender policy. Concerning the gender-based violence project supported by Bill and Medical Gates Foundation. We also have training and mentorship, as well as financing or interest-free loans under COVID-19 recovery and resilience program supported by MasterCard Foundation, among others, and we have quite a number of beneficiaries. Regarding the youth empowerment programs, we have the Kenya Youth Empowerment Project, Project 2011 to 2016. Over 20,000 youths were trained, and more than half linked to internship opportunities to build hands-on experience. There is also the Ajira Digital Project in partnership with Ministry of ICT, MasterCard Foundation, and Immobilis that seeks to train, mentor, and link 2 million youths across Kenya to digital and digitally enabled work. Already, 16,670 youths have been linked to jobs and digital marketing content creation. I'm almost done. We also have catalyzing partnerships and investment into projects aimed at improving the welfare of Kenyan marginalized groups and public-private partnerships with government and development partners on population development projects. The other lesson is about leveraging on the vast number of private facilities and technology to provide innovative solutions to population challenges such as digital health, family planning, community sensitization, awareness campaigns, and so forth, as well as forums to market investment opportunities in the counties with an aim of increasing job creation and reduce rural-urban migration. It includes championing for improved business environment at the national and the county level to support growth for small businesses and access financing and market opportunities. For youth and women empowerment programs, we plan to make them more active economically by including training, mentorship, apprenticing opportunities, financing opportunities, by leveraging on the credit guarantee scheme by the government. Let's go on. We're almost done. The next slide, please. Yeah. So thank you very much. Within the short time allocated, I hope that one sheds some light on what the private sector is doing. Thank you.
Thank you, Madam Mercy, for that well-elaborated presentation. Our chair, for some reason, he's experiencing some technological hitch, but as we sort him out, I would want to invite the next speaker, Dr. Aziz. Please take over and make your presentation. Thank you.
Thanks a lot, Irene. First of all, I would like to express my thanks to our chair who provided overview, and thanks also Evelyn and Mercy for comprehensive presentation. I'm not sure from where will come my slides, from organizers or I should share. Irene.
Aziz, you have the right to present. Please present, because I don't seem to have gotten your presentation. Kindly present, you have all the rights. And we are almost going back to the plenary. So I would urge that we stick within our time. Thank you.
Okay, thanks a lot. So in this case, I will just highlight several issues. As you can see, we are part of 2030 agenda, and we are working together with all UN and other partners on achievement of 17 Sustainable Development Goals. And UNFPA globally organized its work around 3 transformative people-centered results. And you know that from the Nairobi summit, where we had global 12 commitments, all of them are around the ending preventable maternal death, ending the unmet need for family planning, and ending gender-based violence and all harmful practices. And a global estimated cost of delivering the 3 results by 2030 is $264 billion, with the funding gap of $222 billion US. Let me here a little bit give you some facts. Do you know that that $264 billion US price tag is less than the amount of money charged in misconducted fines to the world's top 20 banks? Let me give you another fact. For example, for ending preventable maternal death, we need $115 billion over the 10 years. This is equivalent to the cost of 46 of the world's most expensive military planes. If this were instead spent on maternal health interventions, such as helping women give birth at health facilities with the trained assistants, then hundreds of thousands of lives could be spared every year. Let me give you another fact. Eliminating of FGM, which is cost $2.4 billion in 31 priority countries. For that, we need just put $95 per girl in order to prevent FGM. Another fact regarding the child marriage, which estimated cost is $35 billion US. We should just put $600 to spare each child bride. Taking this opportunity, by knowing this cost, Let me here read a statement of Dr. Natalia Khanem, UNFPA Executive Director's statement. She told us, we now know the costs. These figures are a drop in the ocean compared to the dividend expected and the funds available. What we need next is the political will and financing to get the job done. So as you can see from this slide at the last point, in Kenya, costing of the 3 transformative results is being undertaken through development of Kenya investment case. About it, I will talk a little bit later. So you can see here about pandemic, how disrupted commitment of funding for population-related programs, and consequently, there has been reprioritization of financing of health for COVID response and social protection. And already from previous speakers, we already heard that there is declining contribution to the population programs from member states, development partners, and situation has been further worse by the global crisis. And beginning in 2020, there has been notable constrained bilateral and budgets and the aid budgets and the increased dependence on the international financial institutions, which is keeping us on challenge. And as already previous speakers underlined it now, Kenya is low middle income country since 2014. Therefore, progressively experienced a decline in official development assistance. As Evelyn already highlighted, donor dependency, key programs including sexual reproductive health and rights are over-reliant to donor resources, which is unsustainable in the long run and subject to shocks such as COVID-19. If we look COVID-19 impact, Kenya was hit hard by the COVID-19 shock, reallocation of funds to COVID-19 response. Many challenges remain. Public health is still under pressure with the rollout of COVID-19 vaccines just getting started. So there are a lot of strategies. I just am here highlighted several of them. Of course, none of them separately will not give us what we are expecting. We should continuously mobilize resources, financial resources from member states to support of population programs, development investment cases of 3 transformative results. Now, UNFPA added to this tool also a module specially related to impact of COVID-19. As I already mentioned at the beginning, we are under the ownership of government of Kenya and under the coordination of NCPD. UNFPA is providing technical assistance. We started to having this investment case. So, but when we will have this investment case, we will know actual cost, how much we should allocate in order to achieve those 3 transformative results by 2030. And this investment case can be used not only for advocacy for risk mobilization, but also for planning of government priorities till 2030. If we will not have enough investment for our population and development programs, then it will be high risk to achieve 2030, our targets. Establishment of and strengthening of partnerships with private sector and development partners. It is very important, and private-public partnership is one of the room. And here, in addition, what Kepsa already highlighted, from UN side, we have UN strategy SDG partnership platform where we are engaging private sector. And then last but not least, this is exploring of innovative financing options. There are several options to have development impact bonds, to have very good population programs. Currently, UN team with partners are working for the adolescent sexual and reproductive health development impact bond proposal. We shared it with SDG Financing Secretariat, and we got good rates. And I hope by the end of year, we will get good results. So I fully agree with previous speakers that there should be national ownership. I changed it, funding to financing. If you can see in my slide, we should not more talk about funding. We should talk about financing. And financing first should come from national part. And in this case, when we will have investment case, and also when we will show, we will demonstrate government's allocation to population and health programs, then we can attract other donors, development partners, and also UN to join to that programs. So we should also look at another way of financing options, innovative way. We should do things, particularly risk mobilization issues, another way. One of them I already highlighted, this is development impact bond. And also having sexual and reproductive health and rights package as integral part of component of UHC benefit package. We are, from our point of view, it will give great impact to make significant progress upcoming years. Integration of sexual and reproductive health and rights in the post-COVID recovery plans. We should think about it now, not later on. Introduce ICPD marker in national and county budgeting for monitoring budget allocation as well as expenditure. One thing is just saying that we allocated. Another thing, look at real expenditure. We reach it to our beneficiaries or not. Strengthen financial accountability for ICPD 25 commitments by non-state actors. If you remember, in Nairobi, there was not only government's commitment, but there also was several non-state actors' commitment. And also we have in Kenya, hundreds non-state actors working in population and development programs. So we need.
I'll just give you 1 more minute.
Yes, I will do it 3 seconds, sir. So we will need monitoring in order to have financial accountability. Of course, we should have established partnerships with various organizations working in health, protection, data, and other population-related areas. Only such kind of multi-partner, multi-sectoral approach will give us room to achieve our targets. And of course, ICPD 25 commitments should not be just alone, but we should integrate it to the upcoming. For example, UN now is shifting from UNDAF to UN Sustainable Development Cooperation Framework. And tomorrow there will be launching Generation Equality Initiative. So ICPD 25 commitments should be integrated to this initiative. And you know that Kenya is championing Generation Unlimited Initiative. So ICPD 25 population and development programs should be integrated to these initiatives. I am done, Chair. Thanks a lot for this opportunity to highlight some part of issues today in such very important forum. All the best.
Thank you very much. And thank you very much to all the other presenters. I think they've given us very valuable content for us to think about. I just now want to quickly, in the next 5 minutes, open this up for to the plenary. You can't hear me? Can you hear me?
Yes, Chair.
Yeah, very well. So I just want to quickly open this up to plenary, and in no particular fashion. So probably you could ask, and we have the panelists here to respond. If we could see who is asking, that's better. But either way, you're free to ask. Any comments?
I am seeing in chat box, Chair, we need to advocate for domestic financing of GBV programs to breach the funding gap. So I fully agree with Cosmos on this highlighted issue. And as I already told that we are developing investment case. An investment case we will have for GBV general, then for ending of FGM, and also ending child marriage. So this tool will be, as I already highlighted, very tangible, evidence-based a tool for advocacy as well as for risk mobilization. Over to you, Chair.
Thank you. Anyone else? Just something I think I noted from the UNFP, from Dr. Helenov's presentation, how I wish we had Treasury and National Planning here. But I sit in the Budget and Appropriations Committee. I'll try and see if I can raise it in one of the forums, because we are currently in the budgeting cycle. The need to include population initiative funding as part of the post-COVID-19. I have seen in part of the budget highlights, there's some funding that has actually been put aside for what they're calling the almost about 30 billion, 29, about 30 billion for post-COVID recovery, different initiatives. Maybe we need to consider this, and I think I'll take it up because Treasury will appear before us. Someone asks also in the chat that any financing plans towards modern natural family planning. I don't know whether Dr. Helenov, you want to take this?
I didn't get fully question, but we are having with the government of Kenya forecasting plan for contraceptives for several years, and we are through that one with the government trying to have sufficient without any stock outs family planning commodities. So this is a planned way, and if we will get this year our Kenya demographical survey, we will look at how we are growing up in compared with the previous one. In general financial planning, this is a plan how much we should get for serve our women and girls on contraceptives. It is there, and then based on this we are mobilizing resources from government and also from development partners, including UNFPA. Over to you.
Thank you. Thank you. I have a message. There are two. One is actually direct to my inbox, and there's one of the participants proposing that to generate local resources for population activities, she recommends a local tax on population that is directed to family planning and GBV, like NHIF cards, like NHIF funds. Well, I don't know how that would work with the context of already an overburdened population coming out of post-COVID recovery, or maybe we just restructure what it is. Good suggestion. Steve Biko says, as a matter of policy, can the government prioritize on youth-friendly sexual reproductive health service with a very specific budget line within every budgetary allocation from the national to the county? Should be made as a mandatory requirement. I think this was also captured in one of the presentations. I think as a takeout, we will try and put this as our recommendation to Treasury to consider. Not only budgeting, like someone said, I think the first speaker, not only budgeting, it is from allocation to actualization, availing the funds. Any other? The other issue, I think, finally, that also stood out for me is to have innovative ways of funding, because things are changing pretty fast. The disruption has changed our prioritization, and everyone now is focusing on COVID. We don't know whether we're going to be hit by another pandemic. So if there is no any further question, I think our time is up. Actually, we are slightly above by a minute, unless someone has anything. Elizabeth Sianda.
Yes, Chair. Yes, Chair, this is Ezekiel.
All right. Go ahead, Ezekiel.
This is Ezekiel from UNFPA. Thank you for the good presentations. One of the things that I have noted from all the sessions is that there's a recommendation to invest in research and innovation. And I think this is one of the areas that has been highlighted, that we don't have adequate funding to do research, population research, and also the innovation to the same. And this is a request to you, Chair, and also the other members of the Parliament, and also the other planners and those who are involved in budgeting, that we allocate more funding in this area so that we can be able to inform the decision making within our programs. Thank you.
Thank you very much, Ezekiel. On point, well taken. Elizabeth, your message also is taken, that she says any financing plans towards modern natural family planning. Well, she's saying we still need to consider that is relevant within our cultural and religious values. There are those who do not want to use modern contraceptives. Well, loud and clear. So we will try and see into that. Now, in case you have any other submissions or recommendations or any comments that you would want, you could still forward this to the email address that has been posted by Irene there, policysubmissions@ncpd.go.ke. If you do also share with her your email addresses, Irene, I want you to probably pick up the presentations from all the panelists and my own. I've forwarded it to you. We can then share it with all the participants just for their future considerations. Thank you very much, and God bless all of you.
Thanks a lot, Chair.
We are looking as if there are any
Thank you,
clarifications that delegates would like to have. Please, we have about 10 minutes.
Say that again, Peter.
Yeah, we have got about 10 minutes more.
Okay. Very well. Thank you. Thank you for the generosity. Yeah, we started a bit late. So anyone else with anything that is still burning, we coordinators are gracious enough to add us 10 more minutes. So other than the policy submissions at ncpd.go.ke, Irene has put in another email, which is there. I'm seeing a couple of guys just putting in their email address. Please, Irene, note all the email addresses, and after this, please share presentations. I think NCPD and all these other stakeholders, including the private sector, and ourselves from the National Assembly, because we run the budget, it would be good that we have maybe more frequent interactive sessions, because in this century, things are moving pretty fast. So we might plan for a 2-year plan or a 1-year plan, and things keep on changing. Yeah, the email addresses keep on coming. Yeah, so that we can continue to update ourselves. Mercy from KEPSA, I saw some of the issues you spoke about, the rapid population growth vis-a-vis the employment opportunities that emerge out of it, the high dependency ratio as a result, of course, of the population growth, congestion on infrastructure. We need to have short-term plans to address the same and long-term, because things are pretty changing. I know we have been, as with the National Assembly, there's been those roundtables we keep on having with you to discuss where there are policy gaps that we need to intervene, and those will continue. Ladies and gentlemen, I think we can end it there so that we break for lunch as we look forward to the afternoon sessions, if there are any. No, I think this is the end of day one. Asante sana. Back to you, Peter.
Thanks you, Chair. Thank you for facilitating this session. We would like to appreciate our able panelists and also the contribution we have gotten from our delegates who are in this session. What we are doing here is from here now, the rest of the parallel sessions will come to plenary. We take a few minutes from each session. We pick the chairs of the various sessions will share with us the takeaway 4 or 5 issues which stood out during the breakaway sessions. So the rest of the delegates from other sessions are also joining us in the plenary now,
Another 10 minutes.
so that we can be able to conclude in the next 8 to 10 minutes. They are still on.
Asante sana, but we can now leave. Thank you. Thank you.
The rapporteur can assist you to wrap up the key issues which you can be shared in the plan with the rest of the sessions. Irene, please, with the other rapporteurs, we can pick 4 or 5 key issues you can share with the rest of the other delegates in the other sessions. What came out from the business session? Thank you.
Irene?
Delegates, we request that please you give the other team about 6 minutes so that we can have a wrap-up session. And we don't log off. We give the other 3 concurrent sessions about 6 minutes to wind up, then we can convene for wrap-up. We are requesting not to log out. We need to have a feel of what was happening in the other sessions. Thank you for your indulgence. back to the primary.
Okay, start again.
Welcome back to the plenary session. I wish on the onset to really appreciate each one of us for heeding our call in the morning, that we manage time so that we cover all the sessions. And indeed, we have managed to manage our time. We have gone to our various sessions, had the presentation and the discussions. Now we are reverting back to wrap up the day's programs. And in particular now, I request that the chairs from the various thematic sessions give us key highlights for 5 issues. I will request we go by the thematic areas. You can start with the team 1, population size, growth, and age structure. The chair, please give us in team 1, 2. What were the 4 key issues which came from that breakaway session discussions? The take-home messages. Who is going to present it, Dr. Damara? You see him?
No, it wasn't. It's the other session.
The panelists is ready. The chairs from the various sessions. We're going to have a feel of what happened in the various concurrent sessions.
Yes, I was the moderator for the role of education and training. And we have just finished the session, and we had 4 presentations which covered the major areas that education plays in ensuring that the population is skilled and is able to play a key role in the sector. We had Mujuba, who made a very good presentation on the transition, knowing especially that Kenya has had 100% transition from primary to secondary, and is working hard to improve the transition from secondary to tertiary level. We do have challenges in uptake of TVET courses, and especially young people not taking it up, and therefore need for research in terms of uptake. But the opportunity for young people to choose those courses in the TVET sector beginning to grow. And we also had a presentation from the TVET sector led by Evelyn Numbi. She brought out the issue of the youth bulge and how Kenya is taking advantage of that youth bulge, having more young people in the age that can be economically engaged in the society. So the challenge has been the skilling of the young people who are entering the market and making sure that the skills they have are the skills that are needed by the market, and collaboration between education institutions and the learning institutions is therefore key. And then aligning most of the curriculums to the Vision 2030 is a major area. We also had the coordinator of Elimu Yetu Coalition, Bwana Joseph, who presented to us some of the challenges in the sector. Although Kenya has a huge budget in the sector of education, there are still major challenges with regard to how much is put in the development vote, which is a small amount. And also, I think the bigger challenge is how does Kenya budget more money for the education sector, he has put a very key proposal that we need to increase our tax base by making these young people who are coming into the workforce to be formally employed and to become taxpayers of the future. That is a very critical area, and that means a lot of policy alignment to Vision 2030 so that the informal initiatives are formalized and we are able to support the young people to areas that they can deploy their skills properly. We have finished with a presentation from Margaret Wanjiko, who works with an alliance to fight poverty. And we have seen some studies on longevity where you look at the skills, especially life skills that are given to the students so that once they enter the job market, they can be able to make an impact and bring about change in terms of advancement of livelihoods and also creating resilience, especially for the marginalized and the vulnerable women and people with disability. So thank you very much, Chair. That is all we have for the role of education.
Thank you, Reverend Chris Nyanjui, Chair of the Education and Training, which was also a very stimulating session. I had a chance to people in and listen to those presentations. They were very stimulating. Thank you. We will also now do a detailed write-up where we'll be sharing the highlights tomorrow on the education and training. I request the data innovation team in. Kiara, are you in?
Yes, Director, I can say something. Can I go ahead?
Yes. Proceed.
Yeah, thank you. I was chairing sub-team 6.2, and some of the issues which came up was that in this panel, we had Ririan Kimeto, who is actually the Deputy Director, the Head of Communications, ICT Authority. We had also Madam Immaculate Kasaiti. She is the Data Commissioner, Office of the Data Protection Commission. We also had Dr. Damaso Kadenje from African Population and Health Research Center. We also had Madam Joy Kiru, who was representing CHEPOL, although she is also a senior lecturer in the School of Economics of the University of Nairobi. Now, some of the issues which we have been able to pick is that one of them is that we need to the NCPD. Some of these presentations were focusing on NCPD, and the recommendation which came up was that we need to start investing in population issues. Also, there is this recommendation that we need to embed the communication plan or strategy in the implementation plan. Something else which came up during the discussion was that we were informed that the Data Act of 2019 is now being operationalized through 3 sets of regulations. Also, we were informed that for us to move forward, if we talk about data and the importance of data in decision making, that there is need of us having what we call data should be fair. Fair meaning that we are talking about F for fundable, A for accessible, and the interoperability of the same. Also, we learned that working with the partners like APHRC, then we can be able to support what we call the data revolution in Africa. And if we work with this partnership in this kind of partnership, then such a kind of partnership is leading to supporting the functionality of the various subnational data systems. Also, we were informed that we need to start utilizing the scientific approaches in terms of tackling poverty in this country. the proposal which came from one of the presentation was, can we start investing on randomized evaluations? We were given examples of Achira program, the Women Enterprise Fund program, cash transfer program, cash kwa vijana. The question was, what informs the formulation of this? Authoritative would say that these programs are contributing to reduction of unemployment in this country. If not, then it's important we start utilizing these methods of evaluations. Also, we were informed that organizations like JPOL, they also fund research. Therefore, we can also approach them so that we can be able to access resources for research. Also, the team noted that over the years, resources supporting population and development in this country have been going down. Therefore, it's high time as members of this platform and other stakeholders, we start thinking on strategies on how we can be able to start mobilizing resources. Also, there was this recommendation that it's high time we start also investing in data management. We are looking at the capacity in terms of collecting data and utilizing the same. And the bottom line is that we should start embracing technology. Can we invest in technology, because we are talking about real-time data, and the real-time data should speak to technology. I think for now, Bwana Director, that's what I can be able to capture from what we've been discussing for the last 1 hour or so. Thank you.
Thanks, Bwana Ratemo, for that. All right. I will request the Director of Web to come out. Any additional data for your session?
And Dr. Chen.
And Dr. Jen, ICT.
Thank you very much, Chair. My name is Dr. Duncan Ochieng, the Director, National Disaster Management Unit. I was Chair and Moderator for SubDim 5.3, Disaster Risk Reduction. In this area, we had three presenters. One was Mr. Elijah Muli from the Kenya Red Cross Society on human and technological hazards. Then we also had Dr. Pacifica Ogola, the Director, Climate Change Authority, presenting on natural hazards. And the third presenter was Dr. John Wafula from UNFPA. He was presenting on the global and national concerns on disaster and risk response and interventions. Chair, I would want to report here that it was observed that the country is prone to all types of hazards causing disasters, both natural, human, and technological. And as such, 5 key areas were considered for consideration by this conference. One is that there is need for us to have a hazard and a vulnerability assessment of the population so as to be able to understand which areas are prone to which type of hazards, and this will definitely inform our response capability. 2, it was also observed that we need to enhance our weather monitoring and be able to give good early warning to the affected populations. 3, it was also observed that there is need for us to clearly look at the issue of the youth and the vulnerable population when looking at issues of disaster risk reduction and more so response, given that majority of the population are youth. The 4th item that came out is the issue of human resource organization, both at the agency level and also at the community level. We need to prepare our personnel adequately in terms of training and equipment. And we also need to go down to the community and be able to build their capacity, because they are the initial responders when we are affected by any hazard within the community. And the last is about the issue of coordination of activities. We know very well that disasters transcend boundaries, and so there is need for us to have a clear coordination framework within the national and the county level governments, so that whenever an event occurs, then the response and the recovery process is effective to the level of trying to save as many lives as possible, minimizing injury and destruction of property. Otherwise, it was a fruitful discussion, Chair, and we want to thank you for that opportunity. Thank you very much.
Thanks, Daktari, for those highlights, and we appreciate the panel that was a part of panel, and also the delegates who were in that session. Can we move to the team which was handling 1.3, the sub-team on vulnerable population and the person with disability? Chair, Director Kitua. Again, or anybody from that group who can give 2-3 highlights? They are not in. Then can we ask the sub-team on fertility, the 2.2, Professor Onyango, on child marriage? Any key highlights from that session? Okay. As they prepare, we can go to mobility general rights. There was a session. This was chaired by Dr. Sek, the DG. Dr. Any key rights? What about the organization? Any key rights from organization? Most of the chairs of the sessions are not in. Any chair who facilitated one of the sessions, please, you are free to share with the rest of the plenary. If not, then I know we have gone beyond the time we had allocated for these sessions. I request that we conclude, and my request is that this has been a very fruitful plenary and concurrent sessions touching various thematic areas on population development. Most of those issues which have been discussed will find their way into our population policy and other related policies and programs. Tomorrow, we are going to start by having a plenary where we can give key highlights of what transpired yesterday and today by the thematic areas. Then we are going to have the closing ceremony, which will be, believe is going to be of very high notes, and I'm extending our invitation to all of you delegates kindly drop in tomorrow. We end the high notes. With that, wishing you a good afternoon. Let us connect tomorrow for the closing ceremony of the session. Will we be able to share with you that? Thank you for the press and concluded with that. But
Thank you.
Thank you.
Hi.
Our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our mission at NCPD is to manage the population. Our mission at NCPD is to manage the population. Oh, our vision at NCPD is to improve the lives of Kenyans. Our vision at NCPD is to improve the lives of Kenyans. Oh, our vision at NCPD is to improve the lives of Kenyans. Our vision at NCPD is to improve the lives of Kenyans. Kenya to develop, we must learn the population. NCPD must provide validation and guidance. NCPD is committed to manage the population, providing education and improve the lives of Kenyans. We are calling on Kenyans to Pangeni Familia. 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 Let's all join NCPD and support population program. Let's all join NCPD and support population program. Oh, let's all join NCPD and support population